Good to go.
The Royal Commission is now in session.
We begin by acknowledging the traditional custodians of the lands on which we meet, the Ngunnawal people and the Gadigal people of the Eora Nation, and we pay our respects to their elders, past, present and emerging. Mr Gray.
Commissioners, in this hearing, I appear with Miss Erin Hill. The Chair and I are located in Sydney. Commissioner Briggs is in Canberra, and the hearing will be conducted by remote links with witnesses in various places, including some pre-recorded evidence. I wish to acknowledge the traditional custodians of the land on which we meet, the Gadigal people of the Eora Nation, and for Commissioner Briggs, the Ngunnawal people, as well as the traditional custodians of the lands from which our witnesses appear over the next 3 days, and to pay my respects to their elders past, present and emerging. The subject of this hearing is aged care provided to people living at home and in other community settings outside residential aged care facilities. By comparison with other developed nations, Australia has a very high percentage of its aged care recipients in residential aged care. In most other developed countries, there is proportionally far greater take-up of community and home care by comparison with residential care. Over 6% of people in Australia aged 65 or over live in residential aged care facilities, the second highest in the OECD after Lithuania, and an astonishing figure of nearly 19% of people in Australia aged 80 or over live in residential aged care facilities. And that's the highest currently or recently reported percentage in the OECD, although Belgium may be higher. That percentage in Canada and the Scandinavian countries is between 12 and 13%. 12 and 13% compared with our 19%. And in New Zealand, it's about 14%. Some countries that are more densely populated manage to sustain far lower rates of institutionalisation in residential aged care facilities, such as Japan at 7% and Korea at 9%. This is likely to be unrealistic for us, but the figures in Canada and New Zealand do suggest that our system is distorted towards institutional care and away from community and home care. There should be far more urgent efforts to prioritise home care over residential care. This is not to disparage residential care. There will always be a place for high quality residential care, but as the research indicates, and I'll come to that in a minute, it's not generally the setting a person would choose. The current COVID-19 pandemic is likely to reinforce people's general preference to age in place at their home and do all they can to avoid admission to residential aged care. As at 30 August yesterday, the most recent day's data reported by the department when I checked this morning, there'd been 7 deaths amongst the nearly 1 million people receiving Commonwealth subsidised in-home and community care, compared with 412 deaths amongst about 200,000 people in residential aged care facilities in this country. The Royal Commission first examined home care in a hearing in March 2019, very early in its inquiry. In their interim report, Commissioners Tracy and Briggs called for urgent action on the long waiting list for home care packages. The government recently announced that since the 2018-19 budget, there has been investment in an additional 50,000 home care packages. Nearly 18 months after the Royal Commission's home care hearing in March 2019 and 10 months after the interim report, people who need more complex or intense care at home are, however, still waiting more than 12 months for their assessed needs to be met. That is, they're waiting more than 12 months after the assessment until they get the help they need. As at the end of the last financial year, there were more than 100,000 people awaiting assignment of a package at the level they had been assessed as needing. Now, many of those people had been offered lower level supports, but they're waiting for the support that they've been assessed as needing. Well-designed arrangements for home care will be crucial for the future of aged care in Australia. Its responsiveness to the needs of older people, its quality and safety, and its sustainability. On the currently available evidence, changes in approach and greater focus and urgency are going to be needed. During the hearing this week, we will be testing a suite of proposals for how best to provide support and care for older people in the home and community. Those proposals are set out in 10 propositions, which we have provided to the witnesses in advance of this hearing. Operator, please display the index to the general tender bundle for this hearing. Commissioners, I tender the general tender bundle for the hearing, comprising the documents in this index.
Of Exhibit 20-1.
Thank you. Tab 1 is a document setting out the propositions I've just mentioned, which are numbered HC 1 to 10. And on the page that's currently displayed, viewers can see proposition H1, the next page HC2, and so forth. We will be testing the 10 propositions, HC1 through to 10, from a number of different angles. I will briefly now outline 5 key themes of this hearing, each of which reflects guiding objectives or principles which the arrangements for home care should promote. Firstly, when older people consider inviting the provision of care into their own homes, they must be confident that they will be able to exert a lot of influence over who delivers that care and how it is delivered. So the first theme is how best to respect the preferences and the choices and to boost control and enable independence for the people seeking support and care in their homes for the long haul. The second theme is how best to transition from the current situation to arrangements that are easy to use, efficient, and can deliver care that meets assessed needs and is guided by the principles of autonomy that I've just mentioned. This will involve eliminating fragmentation and duplication in the way services are currently arranged and lifting current restrictions in supply of necessary services, particularly to people who have more complex needs and are currently waiting a long time for assignment of a rationed package. The third theme is how best to ensure that providers and the workforce have the capabilities to provide the services that are needed. The fourth theme is closely related to the question of provider and workforce capability, and it also involves regulatory oversight and other regulatory functions. This theme is how best to ensure that the services will be provided safely and that they will be of high quality. The final theme is how best to ensure that all of this is achievable in the long term in a sustainable manner. I'll now say something in a little more detail about each of these themes in turn, introducing the proposals or propositions we wish to raise for consideration and to have tested during the hearing, and also mentioning in broad outline form the evidence we intend to call over the next 3 days. So that first theme of preferences, choice, control and independence. The main purpose we submit of home care must be to sustain the health, well-being and the quality of life of older people, enabling them to maintain their independence for as long as possible, to live independently at home for as long as possible, always provided that this can be done safely and that high standards of quality are met. Arrangements for home care should therefore respect the preferences, choice, control and independence of the people seeking help. The importance of this is reinforced by the fact that the care takes place within their own home. And a design respecting these principles will act as an encouragement to people to obtain the services they need in a timely and early manner, when they can best have a beneficial effect. That effect must be to prevent or delay deterioration in functioning, to sustain independence and maintain well-being and quality of life. We hope that this will mean that in most cases, older people can remain in independent accommodation, their own homes, to the end of their days. A report of a 2015 Australian study, tendered but not published, at Tender Bundle tab 5 suggests that for each hour of additional home care per week, there's an association with an appreciable 6% lowering of the chance that that person will ever have to enter residential care. Home care should in this manner act as a stitch in time, preventing or at least delaying much more weighty problems for the individual and much more costly forms of care. These purposes are reflected in our Proposition 10, which sets out measures to ensure an enablement approach is taken to home care from assessment onwards. The preference to remain at home has been a constant theme in both the direct evidence and the expert evidence received by the Royal Commission. Operator, please play and stream the compilation of home care preference testimony that has been prepared.
We're both, Ian maybe more so than I, we're both accumulators, and if we were to move out of our home, first of all we'd have to sell it, then we'd have to buy something else, and then we would have to deal with all our belongings, and that's something we just haven't wanted to face. And we would lose our garden, which we both love. And so as long as Ian can manage those 25 steps, that's not, there's no reason that we would both want to move out.
It is where older people want to, they want to stay at home, they want to be supported at home.
Older people themselves increasingly were voting with their feet and wanting to stay at home.
We know patients and older Australians prefer to remain at home.
And we know that older people want to stay at home. I think that's the other thing that we're hearing. People do not want to live in hospitals for the last 3 years of their life, if that's the average length of stay. People would prefer to stay in their own home surrounded by people that they love and who they trust.
She wanted to stay at home and I tried to keep her at home for at least, I think, 5 months.
It's also a positive experience in terms of providing a loved one with the care that they need and knowing that you're providing the best sort of care that you can and you're allowing that person to remain independent and to remain at home, which is what they want to do.
Thank you. And the available research evidence also supports this impression. This includes recent reports by Flinders University and Ipsos, commissioned and published by the Office of the Royal Commission. Flinders University in their reports state that the overwhelming preference, what they call the vast majority of Australians, is to remain independent and living at home. And a significant majority of 72% would be willing to pay a co-contribution fee to remain at home rather than move into residential aged care. The Ipsos survey report confirms the wish of the vast majority to remain in their own home, living independently for as long as possible. And there are many reasons for this. The predominant theme in the research seems to be that people want to live at home to maintain independence, control and choice as to how they live. Independence is frequently cited as the most significant quality of life indicator for older people. Some people may be afraid of going into nursing homes. This might be because they have witnessed poor and unsafe care of family members, or because residential care is seen as an end-of-life option and means end of life is approaching. Fear of institutional settings is particularly acute amongst certain groups. For example, people who've experienced trauma or discrimination. Home and the surrounding community may have other advantages over traditional institutional care by providing physical and mental well-being that's critical to meet basic human needs. Familiar surroundings confer feelings of safety, comfort and security. People want to stay close to known and familiar services, their GP, other healthcare options, shops, cafes and the like. New surroundings are increasingly disorientating for older people. The Flinders University and Ipsos findings are broadly consistent with the results of a survey conducted for the Royal Commission and published by Roy Morgan. although that survey returned a result that a significant minority of 29% of older Australians would opt for residential care in the event they need care on an almost daily basis in the nature of dressing, eating or going to the bathroom or nursing care, as opposed to simply needing some support in their daily activities. Operator, please display the Royal Commission's research paper number 4, page 48, figure 32. That's the Roy Morgan outcomes, including a paraphrase of the questions that were asked, and the questions in their entirety can be found at the back of the report. Commissioners, the evidence you heard at Sydney Hearing 3 earlier this month demonstrated that there's a lack of suitable accommodation for ageing in place, which may impact people's ability to remain at home in the future. The Ipsos report survey responses also highlight the importance of accessibility features promoting independence and access to community to people planning for housing in their old age. Thank you, Operator. You can take that chart down now. The principle of respecting preferences was central to the government's purposes in establishing this Royal Commission. Commissioners, your terms of reference require you to inquire into challenges and opportunities in aged care raised by, quote, changing demographics and preferences, in particular, people's desire to remain living at home as they age, and, quote, how to ensure that aged care services are person-centred, including through allowing people to exercise greater choice, control and independence in relation to their care, and improving engagement with families and carers on care-related matters, unquote. There are, of course, circumstances in which supported decision-making will be required in order to interpret an individual's preferences. Ms Marie McCabe, Chief Executive Officer, Dementia Australia, has highlighted that as dementia progresses, for example, there will come a time when people are unable to make choices about their care clear. Ms McCabe went on to explain that Dementia Australia absolutely supports consumer-directed care, but that many people living with dementia cannot speak for themselves and do not have carers or advocates who can speak for them. She explained that the system needs to be flexible enough to take into account the unique challenges that many people are faced with. One way in which choice is currently exercised in the direction of home care package expenditure is via online applications through which package holders can arrange care services. Tomorrow afternoon, you'll hear a recorded interview with Eileen Kramer, who, with the support of others, used an online platform called Mabel to arrange home care services directly with workers who suited her needs. Via Mabel, there are thousands of care workers who make themselves available for engagement as independent contractors. That at least is the characterisation placed upon it by a witness we'll hear from later today. And that engagement as independent contractors may be by people who have aged care, home care packages or NDIS support plans. The witness later today is Mr. Peter Scutt. You'll hear from him later this afternoon. He'll explain the benefits for those who prefer to manage their own care arrangements through Mabel and the ways in which Mabel interacts with home care recipients, home care providers and the workers who may be engaged by recipients or providers over the platform. According to Mr. Scutt, Mabel is not an employer, but rather a facilitator of engagement of care workers. He'll also speak about the safeguards that Mabel uses and the differences he perceives between aged care and disability services. Commissioners, there are also critics of Mabel's model and of the brokerage of care services in certain circumstances. One of these critics is Mr. Paul Versteege of the Combined Pensioners and Superannuants Association, who will be giving evidence at the next hearing of the Royal Commission in mid-September. We are tendering his statement now, and it forms part of the general tender bundle. It's at tab 82. Criticisms of such models are also identified by Dr. Paula McDonald in a statement at tab 37. Some submissions received by the Royal Commission also express concerns about platforms of this kind, such as a submission received from the Australian Nurses and Midwifery Union. The Australian Nurses and Midwifery Federation. We will be asking Mr. Scud about these matters later today. We will also call Jessica Timmins, who represents another online platform called Higher Up. Higher Up employs the workers whose profile appear on it, and they're available to provide services to NDIS participants who may select particular workers and arrange the particular services they'll receive by using the Higher Up platform. Higher Up does not operate in aged care, but it provides an example that you might find instructive, Commissioners. One of the witnesses you'll hear from on Wednesday is Dr. Carmel Larragee of the University of Melbourne. Dr. Larragee evaluated a trial conducted by COTA Australia over a 2-year period. Operator, please display tab 46, just the first page, thank you. And this trial was directed to increasing consumer self-management in home care. You'll hear from Dr. Larragee that the literature review she conducted for the trial, which is also available in the tender bundle at tab 30, that indicates that there's a range of better outcomes for older people who self-manage their care in certain circumstances. The outcomes depend, however, on the experience of the provider in facilitating self-management. This suggests that self-management is perhaps something of a misnomer, and we'll explore this later in the hearing. These challenging issues are reflected in propositions HC 3 and 5. The next theme is the simplification of the service arrangements and the integration of the current arrangements into one set of arrangements that will provide a much simpler experience for the person needing care. As the interim report related, the manner in which successive governments and the sector have attempted to meet the preferences of people who need aged care and foster choice, control and independence has been marked by reforms which can be described as marketisation and individualisation. There have been increasing efforts over time to open the supply of home care services to greater levels of competition through providing people with budgets that are known as home care packages. And these packages are supposed to be spent at the direction of the person seeking care on the needs for which they've been assessed. There is, of course, a freestanding home care package program for administering these packages. It has its own assessment processes and 4 levels of funding available depending on the outcome of the assessment. They are level 1 basic needs, which runs to approximately $9,000 a year. Level 2 low care needs, about $15,750 a year. Level 3 intermediate care needs, about $34,500 a year. And level 4 high care needs, approximately $52,250 a year. In the home care package program, there's a basic daily fee and a means-tested co-contribution fee, but the evidence suggests that providers don't always collect the fees and may be omitting to do so as a competitive measure to attract package holders to their businesses. The interim report flagged the need to consider the current government policy trajectory, which has been towards increasing marketisation of aged care services. The interim report foreshadowed the need to explore measures to manage a fragmented market for the delivery of aged care, along with the consideration of alternatives. And that is what we, assisting the Royal Commissioners, have been doing. As you've seen over the course of your inquiry, Commissioners, the home care package program, I'll be calling it the HCP program at times, sits alongside another program which provides overlapping services accessible through a different assessment process and funded in a different manner. That program is the Commonwealth Home Support Program, or CHSP. CHSP has undoubted strengths that should be preserved to the extent compatible with the need to combine the two into an integrated set of arrangements. CHSP evolved from state-based arrangements and is admirable for its ability to ensure service coverage, even in communities with dispersed populations, and its relative ease of administration compared with the HCP program. CHSP is the mainstay for providing high volume, low unit cost home and community support services at, supposedly, the more basic end of the spectrum for the purposes of preventing people's conditions from deteriorating. It covers a broad range of community and in-home care services, ranging from domestic assistance, social support, transport, meals, assistive technologies, home modifications, some forms of respite, through to time-limited personal nursing and allied health care. Importantly, it did once, but it no longer affords a means of funded care management or coordination. By comparison with home care packages, however, CHSP is weak on the principle of empowerment of individuals' ability to tailor their own supports and care. While the HCP program is, at least in theory, stronger on that matter of respecting choice and independence, it has various weaknesses of its own. Its effectiveness depends on the information that's available to individuals, the willingness and the capability of people to assess that information, informed consumer choice, in short, and also it depends on the presence of competitive market forces in all places and service categories, including for diverse needs. There are uncertainties about all of those matters that I've just mentioned. And there are distortions in the resourcing of the program. The numbers of the packages are capped. And as I said right at the outset, there are significant waiting lists at present. The packages are only meeting about half of the call for services to meet higher, more complex care needs that have been assessed. Notwithstanding that people are not getting the packages they need in a timely fashion, people who do have packages are not spending all the money they're entitled to spend, leaving a large and accumulating pool of unspent government funds in the hands of providers hosting the packages. Who are the home care package providers? At the end of financial year 2018-19, there were 928 of them, 52% of whom are not-for-profit organisations who enjoy a 72% market share by number of package holders. 36 of the home care providers are for-profit organisations enjoying a 22% market share, and the remainder are government-owned. The providers were funded about $2.5 billion to provide services in that financial year to about 106,000 people at a point in time, 30 June 2019. The number of people who had packages on that date was up 16% from the end of the previous financial year. And the numbers of people holding a package are generally on the increase. They've been increasing year on year for the last several years. The average age of people holding a package was about 81 years old. The number of packages assigned to older people has risen since the end of financial year 2018-19, as I just mentioned. By December 2019, it's reported that 145,320 people had access to a package. And as at 30 March 2020, 151,958 people had access to a package. There were more than 1,450 providers funded to provide CHSP services in the nature of home support in that financial year 2018-19. The cost of that program was similar to the cost of the home care package program. About $2.5 billion was spent on care and another $100 million on support services such as assessments. The people receiving those services is far greater than the people receiving services under the HCP program. Under CHSP in 2018-19, about 840,000 people received services. The average age of those people was 80 years old. There are also in that financial year about 564 CHSP funded respite providers. There's broad consensus in the submissions to the Royal Commission that integration and simplification is needed, but the optimal form the new arrangement should take is contested. Following a consultative process and a hearing, on the 4th of March 2020, we made submissions to you, Commissioners, about the key elements that should guide the redesign of the program for aged care services, including home and community services. Those submissions are published on the Royal Commission's website. Further submissions in response have since been received from stakeholders, the public, the sector. Consistently with our submissions on 4 March, we've now formulated more detailed proposals for integrated arrangements in community settings and in the home. Operator, please display Tender Bundle tab 59, just the first page, which is our outline of proposed new arrangements. The proposal for these new service arrangements is set out in some detail in this document, and this document's been made available to witnesses in advance of the hearing, and it's publicly available at tab 59 of the General Tender Bundle. Operator, please go back and display the propositions at Tender Bundle tab 1, Proposition H2. Commissioners, our Proposition H2 is intended to meet the need for adequate provision of support and care in the home through integrated arrangements in a way that extracts benefits from the strengths of each of the 2 existing programs while correcting their respective weaknesses. Some categories of services should continue to be funded in the manner CHSP is currently funded. While the HCP approach to funding is justified in some circumstances, there'll be others where it's not. It will be essential that the full range of community and in-home care services are available to people in outer regional areas and beyond, and to people with diverse needs, such as Aboriginal and Torres Strait Islander people, other people who are culturally and linguistically diverse, people affected by trauma, people who are or are at risk of being homeless, people who are socially isolated through disadvantage or through stigma, such as former prisoners. In many cases, a market-based model may be inadequate, and the government should commission providers through direct grant agreements to ensure services available in these circumstances and for these people. Operator, please display Proposition HC1. That proposition and various detailed proposals in Propositions 4 and 6 are all designed to enable a transition to the new integrated home care arrangements. HC1 is a set of interim arrangements for a transitional period, which should be no longer than 3 years in our submission. The objective is a demand-driven, uncapped set of services where everyone is entitled to aged care and will be guaranteed access to the care they've been assessed as needing. This approach serves the principle of sustaining people in their preference to age at place in their home wherever possible. And if that is to be achieved, the key issues of capability that are addressed in the later propositions, in particular HC6, must be prioritised with the assistance in HC4. I'll address those propositions a little later in these remarks. We'll be testing our proposals for the structure and features of the new integrated services with a panel of providers this afternoon, including a small provider with an innovative niche suite of services, Mr. Ahlan St George of Vitality Club, and with a provider with a specialisation in care management of services for vulnerable people, Mr. Brian Cooley of Community Options, and also with Ms. Sharon Brower of Meals on Wheels South Australia, and 2 witnesses from large-scale home providers associated with Uniting Care Australia, Uniting New South Wales ACT, and Uniting Agewell. As we foreshadowed in our March 2020 submissions, Commissioners, the new services should be uncapped and demand-driven, not rationed. More than half the people who need packages for more complex needs are currently waiting more than 12 months on average and may miss out on ever receiving a package. Despite releases of additional packages earlier than originally forecast in the budget forward estimates model, with the result that the number of packages in the hands of people has climbed, as I outlined earlier, it's still the case, as at March 2020, that a total of 103,599 people were waiting for a package at their assessed level. And that included 59,071 people waiting for a package at their approved level who'd not yet been offered a package at a lower level as an interim measure. Now, that many of those people might be receiving CHSP services. To some extent, the resources of CHP are being diverted from CHSP's critical preventative role and being used as a stopgap to meet demand for those higher level needs. People typically underspend their home care package, saving for a rainy day. And as at March 2020, it's estimated that there were accumulated unspent funds of over $1 billion. And Stuart Brown estimated then that by July this year, that figure would be $1.1 billion. And that represents more than $8,000 per package holder on average. If this allocative inefficiency were remedied, funds of that kind could be deployed in releasing more packages to meet the needs of people who are waiting in the queue to receive one. Although package holders are generally underspending their package, it seems that for some people, even the highest value packages are inadequate to provide the level of care they need to remain at home in some circumstances where the community might expect that they can. Evidence on this point will be led in the funding hearing in mid-September from Dr. David Panter and Mr. Martin Warner, and their statements are before you now. They've been tendered at tabs 68 and 69. The delivery of services to holders of home care packages depends on what is called consumer-directed care. But as evidence in Adelaide Hearing 4 back in March, in Adelaide Hearing 2 back in March 2019, and evidence in the Mildura hearing has already shown, consumer-directed care does not work properly because of information deficits, difficulties in navigation of the system, and the widespread lack of sufficient depth of supply of necessary services, particularly in rural and remote areas. The fact that the two programs are assessed and also administered separately, causing confusion, is a distortion that must be addressed. There are also arbitrage opportunities created whereby people choose not to take up a home care package because they perceive that in their area it may be more advantageous to them to stay on CHSP even though they're assessed as now needing a home care package. It makes little sense for the two programs to continue side by side with the overlap and distortion that I've mentioned. The challenges of integrating them are going to be tested during this hearing with the witnesses, starting with the witnesses we're calling today from the providers I've mentioned. The third theme, Commissioners, is provider and workforce capabilities. Increasing the supply of home care subsidies will require providers to scale up their operations. Further, increasing the availability of funding will be of little use and could even have harmful effects unless there's a sufficiently numerous and appropriately trained and supported workforce available to deliver the care to be purchased with those subsidies. As propositions HC1 and 2 describe, our proposal is that the level of funding available in home care should increase to the maximum that that particular individual would receive if assessed for residential care. Operator, please display GTB 69, the statement of Dr. Panter at page 5, paragraph 12. Dr. Panter is a provider. His organisation is a large-scale South Australian home care provider, ECH. ECH conducted a trial of this same approach, that is providing a home care budget equivalent to the budget the person would receive for the care component of residential care, with a small number of its home care recipients, and had good results. The logic behind this proposal is that permitting the recipient to spend up to the level of the care component of what would be spent on them in residential care, enabling them to spend that care money in the setting of their choice, could serve to keep that person out of residential care, meeting their preference and sustaining their independence. And in theory, this should be cost neutral to the Commonwealth and might in fact save the Commonwealth from paying accommodation-related subsidies that would occur for some people when they move into residential care. On the other hand, it might be said that for complex and intense needs, it's more efficient to fund services in a congregate facility than to fund services at home. That issue will be tested at the hearing in mid-September. However, increasing the number of packages and the level of packages, that is the level of funds available to people with complex and intensive needs, means that people with complex needs who are currently compelled to enter residential aged care should be able to remain in their homes for longer, and this entails the building of capability in the current providers of in-home and community care so that those people can be properly cared for. Proactive management by government will be needed to ensure that there are providers who have the clinical capability to provide that care. We'll be asking a panel of experts on Wednesday, consisting of Susan Emerson, RN of the Australian College of Nursing, Associate Professor Lee Fei Low and Dr. Carmel Larragee, to reflect on that issue amongst others. What are the current capabilities of home care providers? We don't know the answers because of a lack of data. Proposition HC6F proposes as a starting point an analysis to identify current levels of home care service capability across the country. The market analysis would be the first step in identifying where commissioning arrangements might be needed to fill gaps. It's surprising and a matter of public concern that little is known about the services on which home care packages are spent. The government does not systematically collect this information. In our submission, that must change. There's proposed legislation which provides an opportunity to enable much better scrutiny to be given to the use of home care funds. If that legislation is enacted, home care payments will no longer be paid in advance, but will be paid in arrears. And that should be an opportunity to collect data so that government can understand the performance of the aged care system, which is a necessary first step before necessary refinements can be made over time. In the interim, and in order to provide some basis for inferring what services have been purchased with home care package funds, the Department of Health conducted a survey of a large sample of home care providers, which has since been analysed by Stuart Brown. Operator, please display tab 4, just the cover sheet. Now, for one financial year, there was a significant sample of almost half of home care providers surveyed for the purposes of this study. So the survey has a sound basis in evidence, and it shows that there is extremely low utilisation of certain services, unexpectedly low utilisation of nursing and allied health services, even for people on packages intended for, even people on the packages intended for the most complex needs are on average receiving only about 15 minutes per fortnight of nursing care and about 15 minutes per fortnight of allied health care, amounts which Stuart Brown rightly describes as negligible. This does not seem in any sense to be sufficient for dealing with complex needs. We'll be testing in proposition HC9 whether a minimum contact period for people with clinical, medical and personal needs is required. There's much to be done by government to support the training and supply of the necessary workforce and the development of career path opportunities for improving the skills of existing aged care workers and for encouraging entry into more advanced job classifications. Proposition HC4 proposes funding that would assist these measures. As we previously submitted, government should be implementing the 14 strategic actions recommended in September 2018 by the Aged Care Workforce Strategy Task Force headed by Professor Pelares. Those actions recommended 2 years ago are more urgent than ever now. Ironically, the effect of the COVID-19 pandemic on unemployment rates may present an opportunity to increase and improve the aged care workforce if government moves quickly on this. Increasing the supply of home care subsidies must not compromise safety and quality. Council Assisting have already made a recommendation to you, Commissioners, in February this year that all aged care workers providing hands-on personal care subsidised by the Commonwealth should be required to have a minimum qualification at Certificate 3 level and to be registered. In the home care setting, we'll ask witnesses whether, if there's a likelihood of the personal care worker being unsupervised, the minimum qualification should in fact be greater, perhaps at a Certificate 4 level. Technological innovation has previously been addressed in a separate hearing and is not a particular focus of this hearing. That said, there will be a focus on the use of online applications and platforms to arrange care services. Technology affords opportunities for improving the reliability and efficacy of home care and improving consumer choice and engagement, but it also poses potential threats, including threats to privacy and threats to workforce stability that have flow-ons to quality and safety. Deployment of new technology needs to be monitored and managed by thoughtful and proactive system governance and not simply left to market forces in our submission. Propositions HC 6A and B propose measures to improve the capability of the workforce and its stability by improving the arrangements under which the workforce are engaged and deployed by providers. The recently released report of the inquiry into the Victorian online demand workforce reveals that between 2014 and 18, the number of independent contractors in health and social care increased by 29%, compared with a 19% overall increase in that workforce. Online platforms are playing a role in the trend towards the increase of use of independent contracting. In February 2020, we made submissions about the future challenge of attracting people to work in aged care, given future demographic predictions. We submitted that the Royal Commissioners have the opportunity to set the policy parameters to provide aged care workers with the training and support that they need to have a fulfilling career with opportunities for professional development and an attractive career trajectory. This week, Commissioners, you'll hear from a panel of workforce experts, Dr. Fiona McDonald of RMIT, Dr. Jim Stanford, Director of the Centre for Future Work, and Professor Andrew Stewart of Adelaide University, about impacts for the aged care sector in personal care workers providing services as independent contractors. We'll be asking those witnesses whether the emerging trend of engagement of independent contractors impacts on building the attractiveness of aged care as a career destination, and we'll ask whether there are links between quality and safety of care and the employment or engagement arrangements for personal care workers. We'll also ask whether there is the risk of compromising quality and safety in circumstances where personal care workers are not subject to direction and control of a clinically qualified person within an aged care provider organisation. The fourth theme flows straight on from that point. It's ensuring quality and safety for services delivered in the home. And in considering this theme, we have to acknowledge that the regulation of quality and safety of services provided on private premises has been a regulatory weak spot for some time. Now, it's evident in our submission that strong care coordination or care management is needed if there's to be reliance on a marketised model to answer needs of people, including needs that may be very challenging and needs arising from diverse backgrounds. Operator, please display General Tender Bundle tab 12, the statement of Daniel Doherty of Mallee District Aboriginal Services. Ms Doherty gives evidence in her statement about what amounts, these are my words, what amounts to the misuse of home care packages. Ms Doherty has said that many clients have received a generic service that's not tailored to their needs and does not allow for changes to be made quickly and easily to accommodate evolving needs. And over on the next page, she gives examples of some providers sending care recipients vouchers for food or retail stores without having properly assessed their needs. And in some cases, people being left unable to purchase necessary therapeutic equipment with dire results. Care management must be done appropriately, and it will involve referral for reassessment when a person's needs change, and it will involve well-resourced and nimble assessment services able to provide punctual reassessment. Otherwise, a marketised model will not be able to succeed. Now, care management, in spite of its importance, is not uniformly well understood or practiced. Margaret Harker's statement in last year's home care hearing gave an example of poor care management and problems that can arise when care management is separated from the workforce that provides that care. And operator, we won't play the video of Margaret Harker's evidence, but it will be made available for the public to view it as part of an addition to the tender bundle. We will test with witnesses our propositions to clarify and strengthen care management, which we say should be a mandatory function performed for all residents of care at the home under the new arrangements. The key issues will include how such a care manager is to ensure that care provided is integrated with all the other services that are available to older Australians from health and community sources, what qualifications or experience are required of a care manager, and how important is a clinical background for a care manager. During Adelaide Workshop 1 in February this year, Professor Parker of the University of Technology, Sydney, and of the Australian College of Nursing stressed the importance of maintaining oversight for people receiving even supposedly basic services and of assisting people as their needs change. She outlined the basis of care management, quote, that we do want to make sure that people are getting the right assessment, the right care delivered by the right people at the right time. Now, of course, it can't always be left to the person receiving care to ask for more. Ms McCabe of Dementia Australia has reinforced the point that the needs of people living with cognitive impairment caused by dementia need to be considered in that regard as well. Current data drawn from the recent survey of home care providers I mentioned that's been analysed by Stuart Brown, as I said, indicates that very little of a home care package is currently used for nursing care services. Now, the picture presented by these data raise real concerns that inadequate clinical expertise is being brought to bear in the care management of people with complex needs who may need assistance in coordination of primary health care, allied health care, and potentially subacute care, as well as personal care services. And the data also show that there may be a deficit in clinical care more generally. Although the primary onus must be on the provider and its care management, there's also a role for official monitoring and quality and safety regulation. It's long been recognised that the regulation of quality and safety in home care on private premises is very challenging. Because it's delivered behind closed doors in private homes, and it's delivered to so many hundreds of thousands of people, this makes it very necessary to consider ways in which safety and quality can be indirectly measured rather than directly monitored and observed. The challenge will become more acute as more people choose to age in place in their homes. Officials of the Department of Health have acknowledged to the Royal Commission that the regulation of care in the home is less developed than the regime that applies in residential care. The government has a plan for improvement of quality and safety in home care, set out in a document generated last year called the Home Care Compliance Action Plan, and that's in the tender bundle. And the regulator has a project to achieve similar broad objectives. We'll be examining these plans in sessions with witnesses from the department and from the quality regulator on Wednesday. This afternoon and on Tuesday, we'll be hearing about safeguarding arrangements for people provided with services in the home and community. We'll hear from Professor Josh Scholes of Maastricht University on various aspects of home care, including safety measures in the Netherlands. And tomorrow, we'll hear from Commissioner Robert Fitzgerald and Ms Catherine McKenzie of the New South Wales Ageing and Disability Commission on these topics. In propositions HC6C, we propose higher hurdles for suitability before a provider is licensed and certified or approved to provide care. New home services should receive a prompt quality review against the quality standards immediately upon commencement of services. At present, many months may pass before this occurs. This is unacceptable, at least in cases where the provider doesn't already have a proven track record of high quality and safe services. In proposition HC7, we propose an overarching general duty on providers to ensure high quality and safe care. This duty will be an important element of the overall approach to quality and safety across all forms of aged care, including home care. Measures for consumer feedback and engagement will be a key element of home care quality regulation. And measurement of quality indicators can play their part. On Tuesday, you'll hear from Dr. Gillian Corhy of ROSA, the Registry of Senior Australians, about research she has conducted and overseen for the Royal Commission into the use of quality indicators in overseas aged care systems, and we'll examine the categories of indicators that might be appropriate for monitoring in the home care context. Amongst other propositions in HC6, we propose an extension of the serious incident reporting scheme that currently applies in residential care into aged care settings, at least where higher level care needs are being met in the home. And we also propose to draw all these information sources about provider performance together and establish a transparent public reporting regime to inform consumer choice. All of these measures will place additional burdens on the regulator. The regulator must be properly funded, staffed and supported for these tasks. And there's reason for concern that the current levels of resourcing of the regulator and its current capabilities may be inadequate. I turn now to that critical issue. There appears to have been a steep fall in regulatory activity by the regulator since July 2019. The new quality standards were introduced at that time. It might have been expected that the regulator would seek to increase activity to encourage adherence to the new standards. However, since that time, there's been a fall to give you an illustration of the level to which regulatory activity has fallen since that time. Commissioners, I'll give you an example of the quarter before July 2019. In the quarter 1 April 2019 to 30 June, in the quarter 1 April 2019 to 30 June 2019, there were 181 quality reviews conducted by the regulator on home care providers. In the next quarter, after July 2019, there was a huge drop. And in the 3 quarters since July 2019, for which we have a report, there's been an average of only 25 quality reviews in each of those quarters. 25 quality reviews compared to 181 in the quarter before. The Aged Care Quality and Safety Commission has explained in response to a notice issued by the Royal Commissioners that the level of home care service compliance activity has been impacted by high turnover of the assessor workforce. Also, the introduction of the quality standards, which has increased the time taken for quality assessors to undertake assessments, and a higher number of non-compliances identified in residential aged care. Commissioners, in the budget for 2019-20, the government announced $5.6 million to commence implementation of an enhanced home care compliance framework. In addition to asking witnesses about the progress of that framework, we'll be asking witnesses about the capability issues and the staffing issues that I've just identified. Finally, Commissioners, your terms of reference require you to inquire into how best to deliver aged care in a sustainable manner. Sustainability will be a key focus of your next hearing on funding, financing and prudential arrangements in mid-September. But it's also an important principle to consider in relation to home care. If the system of aged care services could get home care right, as well as meeting the preferences of older people, this would probably alleviate fiscal pressure on the system, at least to some extent, and that pressure is severe. Home care is cheaper than residential care on a per capita basis and is currently much cheaper on an aggregated basis too. The average Commonwealth funding paid for someone in residential care in 2018-19 was about $191 per day, whereas the average daily expenditure by providers for a person on a home care package was about $71 in that period. In aggregate terms, CHSP and HCP together cost the government a little over $5 billion in 2018-19, and residential care cost the government about $13 billion in that period. I want to mention very briefly the importance of respite in meeting the needs of informal carers in particular, and in sustaining the system of provision of home care services. The provision of home care services to a large extent depends on assistance by informal carers. The current system for provision of respite is badly flawed and is geared to providing inflexible chunks or blocks of time in residential respite when the evidence shows that informal carers would prefer to receive respite on a far more flexible basis, including short stay or overnight respite. There needs to be a dedicated set of arrangements for respite, and you'll see that in our propositions, in particular proposition HC2. Operator, please play the evidence of Miss Rosemary Cameron at the Mildura hearing.
I learned that you don't wait till you need respite, that you book ahead so you know you've got a set break in, so you can pace yourself virtually, because you won't get anything at the time. So sometimes I would book it in and it'd be 3 months ahead, and then I'd get a few weeks just prior to going in, and you're hanging on thinking, well, if I just hang on a little longer, I'll get that respite. And then they'd ring me to say, I'm sorry, that bed's not available now, we've filled it with a permanent resident, so I'm sorry, you can't have that. So then you've got to ring again and wait longer, again. So you just put to the back of the list. A lot of the facilities were closing down their respite beds, and it was told to me by one facility that it really wasn't worth them doing all that paperwork every 2 weeks. If they did 2 week slots for respite, then it was far too much paperwork. If they put a permanent resident into that bed, it was easier. So they were stopping their respite beds.
As well as having difficulties in obtaining respite, and in spite of being assessed as needing a high-level home care package, that package was never assigned to Mrs. Cameron's husband, Don, and there were times when Mrs. Cameron almost despaired. In the future, aged care needs assessment must include a focus on the needs of informal carers, and a tailored package of respite must be available to support them in the long term. and it should have a dual purpose, providing relief for the carer as well as improved enablement outcomes for the person receiving care. We propose that the respite category of services should be grant funded and commissioned regionally so that there are local solutions for local needs. In addition, to sustain and incentivise these informal carers in their vital role, we propose at HC8 a new measure to protect the workforce participation rights of informal carers. One of the issues highlighted in the Mildura hearing was the difficulty for informal carers in continuing with employment for a period of time when caring for an older person. A panel tomorrow will consider the new employment rights we propose under Proposition HC8, which concern extended leave and flexible working arrangements for carers. Commissioners, I'll conclude by just saying this. The 5 lines of inquiry, which I've just mentioned, each provide insights into bringing about lasting improvement in home care, but of course they can't be considered in isolation from each other. I'll be asking the witnesses to consider the ways in which these matters can best be combined to deliver lasting improvements, and this will involve careful consideration of tensions which exist between them. Commissioners, I understand there are now some appearances to be made or announced.
Yes, thank you, Mr. Brown. Do we have some appearances?
I can't start the video. I may please the Commission. Can I be heard? My name's English.
Yes, Mr. English, you can
I
be
seek
heard.
leave. Oh, thank you, Commissioner. I seek leave to appear for Mabel Technologies Pty Limited.
Yes, thank you, Mr. English.
Please the Commission.
Commissioners, I appear for the State of Victoria. My name is Holt.
Yes, Ms. Holt, I think we can just barely hear you, but if I've understood you correctly, you're appearing for higher up in respect of the witness, Jess Timmins. Is that correct?
No, Commissioner, I appear for the State of Victoria.
Oh, sorry, I misheard you completely. Yes, thank you.
Thank you.
As I mentioned earlier, Commissioners, during the hearing, I'll invite you to receive pre-recorded videos of evidence given by direct experience witnesses, together with related documents. There are going to be 3 such recordings. The first of these is evidence of Rod and Rosalie Foreman. I tender the statement of Rodney Foreman, document ID RCD 9999 0479 0001. Commissioner, I could tender the entire set of documents relating to the recording of this evidence as one exhibit if
Well, I think that would be preferable, wouldn't it? Unless for some reason why it should not happen.
I'll recite the codes for the other 2 documents that make up the bundle. I tender also the recording of Rodney and Rosalie Foreman document RCD 9999 0476 .0001, and I also tender the transcript of that recording, document RCD 9999 0476 .0002. So those 3 documents together, I tender that as one exhibit.
Those 3 documents will be exhibit 20-2.
Thank you, Commissioner. Operator, please play the recording of Rod and Rosalie Foreman's evidence.
This is an interview between Rodney and Rosalie Foreman and Erin Hill, counsel assisting. Today's date is the 24th of August 2020. The interview today is being recorded. The recording of this interview will be tendered at a public hearing of the Royal Commission into Aged Care, Quality and Safety commencing on 31 August 2020 in Sydney. The recording will then be made publicly available. Rosalie, do you consent for Rod to speak on your behalf today?
Yes.
Thank you. Rodney, do you agree to continue with the interview today on that basis?
Yes, I do.
Thank you. Starting with you, Rod, could I ask you to tell us your full name?
Rodney Keith Foreman.
And how old are you?
73 and a half. I had to think about that. Sorry.
And where do you live?
In Mannum, South Australia.
And that's on the west bank of the Murray, is that right?
Yes, correct.
And how far from Adelaide is Mannum?
Approximately 100 kilometres. Depends which part of Adelaide you're going to.
And seated with you today is Rosalie Foreman.
Correct.
And Rosalie's your wife?
Correct.
And you and Rosalie live together in a unit in Mannum?
Correct.
How long have you and Rosalie been married for?
Heading up 13 years in November.
And would you like to share the story of how the two of you met with the Royal Commission today?
Yes, Rosalie had lost her late husband. I was very separated from my previous wife. My sister introduced us. We took a little bit of time to get to know each other, but once we were together in our own time, we just hit it off like house on fire.
And after you were first married, you spent some time in Melbourne.
Not initially. We spent time in Melbourne and Victoria at the time of the stroke, around the time of the stroke.
Pardon me.
Which is 2.25 years ago.
But ultimately, after you were first married, you were living in South Australia.
Yes.
And you were working at that point, both of you?
I was, yes. Rosalie had 2 part-time jobs, courtesy of a challenge from a late husband to go and work for McDonald's. And she impressed the proprietor of a nursery with her knowledge, answering other customers' questions that she was employing.
And when you were both in your early 60s, what did you and Rosalie decide to do?
Rosalie was happy to spend time with me. We spent 12 months in Adelaide to see my son through year 12. We then spent more than 2 years in Port Lincoln. I was lucky enough to work from home on a computer. And when that went belly up, courtesy of working from home, being offshore, we went to live on a houseboat, which we did for about 8 years.
And that was your retirement plans, effectively?
Yes. Yeah.
And did you stay retired?
We did until we started motorhoming 3 years ago, and we were coaxed out of a long-term retirement to run a caravan park in central Victoria, in Charlton.
And how was that experience?
We both loved it. Unfortunately, we only had 7 weeks running it before Rosalie had a stroke.
And when Rosalie had her stroke, what happened? What did you do?
In the short term, well, we were both helicoptered to Royal Melbourne. On the way down, the doctor said next of kin are not normally accommodated in the chopper, but because Rosalie was so crook, he wanted me to be with her. 2 weeks in the Royal Melbourne, 10 weeks in Bendigo, doing rehab at Bendigo Health. And then they wanted to move us on, so Rosalie quite rightly said, I want to go back to Mannum. We still had a very small base in Mannum. We had friends and family within Killy being in Mannum, but not so in Victoria.
And where could you go to live in Mannum?
Rosalie came back basically straight into the Aminia nursing home for the aged. I moved into an independent unit as part of the Aminia complex at the back of Aminia. And so I was able to visit her as often as I wanted, every day, all day, every day. To the point where she was spending so much time in the unit towards the end, and then with the virus, it was easy to get her out of the aged care facility and into the unit.
When Rosalie first went into the nursing home there, what were you told about Rosalie's mobility and prospects of walking again?
The notes that accompanied Rosalie from Victoria said that she would never walk again and that her health was not really expected to improve particularly.
And what did the two of you think about that?
We weren't very keen about it. We had really enjoyed each other's company all the time. We were fortunate to come across a physio who was contracted to work in the aged facility on a maintenance basis, 10 minutes per resident up to 4 times a week. Fortunately, this young lady saw some potential in Rosalie. She asked what our short-term goals were, and we undertook to pay her for additional sessions each week and ticked off all but one of those short-term goals over a number of months.
What were those short-term goals?
One, for her to be able to walk, which she can do with a quad stick and assistance on the other side on her bad arm. To spend time with me, to live in the unit, to get into a car, in and out of a car, which she can do quite easily now. Can't remember the others, so they were documented.
And how did you arrange for Rosalie to receive those extra physiotherapy sessions?
Because the unit was basically within the perimeters of aged care, we could wheelchair Rosalie down to the unit so that the physio wasn't seen to be doing something that she shouldn't be doing, or that Rosalie as a resident wasn't getting more treatment than someone else. So we contracted her for 2 sessions a week, Monday and Friday, and she was still continuing to get the 10 minutes up to 4 times a day when we could coordinate that she was in the aged care facility.
And did those 2 additional sessions have a different focus to the physiotherapy that Rosalie received when she was in the nursing home?
Probably different in that they were aimed at getting her mobility back on track. In the first time she actually walked basically with just the quad stick, I was behind her with my phone and I videoed it and showed the physio, and I've shown several other people, including a couple of friends in Victoria and obviously family, and it was just a great day.
How did it feel, Rosalie?
It's really rounding. It's very
good.
Yes, very good.
And Rod's described that as your mobility improved, Rosalie, that you started spending nights together at the unit.
Yes.
How did you make those arrangements, Rod?
With difficulty in the early days, Rosalie had obviously some referrals through CHSP, and we were trying to access some funding towards an electric bed and a mobile commode and a couple of other things that I was hoping we could get some assistance with, given we'd already parted with money for other things like a Steady Sarah, which is a lifting device, but Rosalie has to do some of the work to pull herself up on that, but then you can wheel her around and put her down on different seats and things like that. But I finished up giving up and basically self-funded with a little bit of help. Electric bed, the commode, because in the short term, early days, I was borrowing the commode from up in the aged care residence. Just perseverance, and I think we're almost set, aren't we?
Mm.
So you described Rosalie having access to CHSP, was Rosalie eligible for aged care services or CHSP or a home care package when she was in the nursing home?
Well, that was the dilemma. In theory, she was eligible, but because she was deemed to be in aged care in a facility, it was very difficult to get. We basically didn't get much access to that. I had myself assessed so that I could get some assistance as social support individual, which with a cooperative provider here, we were able to do stuff on a minimal basis. We parted with a lot of money to get to where we've got to, but that's the nature of the beast, I guess.
And as the time that Rosalie was spending at home with you increased, what did you two end up deciding to do?
Well, excuse me, one of the goals that we had documented with the physio was always to get her home. When the frequency of the sleepovers, as I called them, increased, discussions with the aged care facility said we were only allowed to do that. I think it was 26 or 28 times a year, or she would be deemed to have left the aged care facility. So we were just starting to navigate our way around that, and then the COVID hit. So we knew the aged care facility would go into almost total lockdown. It was just with very restricted access. It was just easier to say, we'll bite the bullet and get her out.
And how long has Rosalie been home now?
I think it's 4.5 months. The 23rd of March was when she came out.
And how was Rosalie home with you?
Great. Yep.
And how do you feel, Rosalie?
Very happy.
Rod, you described that you got yourself assessed. What aged care services do you receive at home?
Some domestic assistance and social support individual. Also some driving assistance in the early days, but I've gone away from that. I basically drive us anywhere we're going now. We were using, the local provider had a wheelchair-friendly vehicle that I was eventually allowed to drive, so I could put Rosie in the back in the wheelchair and go to Adelaide for an appointment. But we get her out of the wheelchair, sit her in the front seat to do those things.
And what aged care services is Rosalie receiving at home?
Level 4 home care package. And currently 3 physio sessions a week, shower and dressing 3 times a week, and podiatry every 6 weeks. I think that's it. And some support while I play 9 holes of golf once a week.
Could you describe to me what support you receive, which you've just referred to in part, when you go get those 9 holes in to support and care for Rosalie?
The carers that coordinate whoever's showering and washing her basically come and sit with her for those 3 or 4 hours while I go to golf. I am lucky to be part of a very friendly group of really aged guys. We call it friendly. I call it friendly competitive. We all go in for one drink afterwards, and so that's, if you are heading towards mental health, that certainly helps me to not be in Rosalie's here 24/7.
Between the services that you require, Rod, and those which Rosalie needs, are you able to access all the services that you need where you are?
No. We're still waiting for some speech pathology, a geriatric assessment, or some help with Rosalie's cognitive skills. And in the early days, I struggled to get my own ear, nose and throat and arthritis specialist appointments. Almost anything in Manham, despite the fact it's only 100 k's from Adelaide, is difficult to come by if you wanted it in the next day, 3 months or 6 months.
Looking to the future, what do you need for the both of you to be able to stay at home?
Certainly a continuation of the current services. Hopefully I won't do anything silly to myself physically, capability-wise, but down the track we might want a little bit more assistance each day for the two of us. That's right now, I think we're fairly comfortable, other than having been told that things like the geriatric assessment won't happen till next year, which is, it's disappointing to hear that. But, and I went through that waiting for an ear, nose and throat specialist appointment and an arthritic appointment. We've been told the speech pathology, I was given, just before Rosie went on level 4 package, I was given the names and addresses of about 7 speech pathologists, but 5 of them won't come past Mount Barker, which is halfway between here and Adelaide.
Why was it important for you and Rosalie to share your story with the Royal Commission?
I think because of we did something which doesn't happen very often. We got Rosalie out of aged care, but I'm not convinced that there couldn't be more situations similar to ours. The fact that we've done it, but I struggled to find my way through what was available, what wasn't available, how to go about applying for it, those sorts of things. Aged care has become a lot more of our focus given our situation. Happy to state our case, put our views across, for want of a better word.
Rod, yourself and Rosalie requested that you'd be able to speak with us today and not later in the week. What have you and Rosalie got planned for the rest of your week?
We're planning to go to Port Lincoln tomorrow for hopefully a week. It's the first time we'll have been away since the stroke. We're taking a carer with us to help me and Rosalie get through each day and particularly night. Looking forward to doing it, and several people we've told of necessity we're going away have said, really great, hope you enjoy it. So it's lovely to have other people supporting.
And what does it mean for the two of you to be able to get away together?
With us, it's more about what people are making us.
Did you catch that? We're going with friends and we're taking a carer who has met the friends that we're going with. We'll be staying in similar situations. They've got a motorhome. We travelled with them in our motorhome and previous to that on our houseboats. So we've known them for 10 years. They're great people. It's just nice to spend some time away, get out. As the physio said, it'll be nice to get out of that unit for a while because Rosalie's in it a lot of the time. I can get out 3 days a week while she's being showered to go for a walk and what I call drip shop, just buy a few things at a time as required. But it'll be nice to go back to where we lived for a couple of years and just experience the Eyre Peninsula again.
Rod and Rosalie, that concludes concludes our interview for today. Thank you for the time that you've been able to give the Royal Commission.
Thank you very much.
Go again. You have to go again.
Thank you, Mr. Gray. Just before you resume, it's appropriate, I think, just in case the foremans may be listening to the video from here, and for all the others who are listening, that we publicly thank them for making themselves available in all this. I'm getting messages that the audio at this end is not working.
Better.
Is it working now?
It's better now, Commissioner.
All right, thank you. Well, third time lucky. Let me repeat by saying that before you resume, Mr. Gray, we should put on record for those who have heard that evidence, and also more particularly for Mr. and Mrs. Foreman, to thank them for having made themselves available. It's a big task that each of these people do when they effectively share their private lives with the entire nation, if not the entire world. It's a big thing, not just time consuming, but a revealing of people's private life is not something that's done lightly, and we're very, very grateful for them in doing so. So thank you for that. Mr. Gray, I think you're now going to ask for a slight break.
That's right, Commissioner. Would that be all right?
Yes, it is. We might make it 10 rather than 15 minutes if that's convenient. So we'll resume it at 1:45. Thank you.
Thank you.
The Royal Commission is adjourned until 11:45 a.m. The Royal Commission is now in session.
Mr. Gray?
Commissioner, I call a panel of 5 witnesses. Firstly, Mr. Brian Corley, Chief Executive Officer of Community Options. Should he be affirmed separately, or shall I announce the entire panel?
You can announce the entire panel first, then we can do them one at a time. Yeah.
Thank you. Mr. Ahilan St George, Director and Co-founder of Vitality Club. Ms. Sharon Brower, Chief Executive Officer, Meals on Wheels South Australia. And Ms. Jackie Attridge, Head of Operations of Uniting Care, Uniting Age Well, and another uniting witness, Mr. Fonda Voukalatos. Mr. Voukalatos is General Manager, Strategy and Business Development, Uniting Age Well and Uniting New South Wales ACT.
Yes, thank you.
Mr. Corley, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Mr. St George, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Ms. Broad, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Ms. Attridge, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Mr. Voukalatos, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Yes, thank you. Mr. Gray?
Commissioner, there's another appearance. I believe there was a technical difficulty preventing this party from announcing its appearance at the outset, and I'll allow that party an opportunity to be heard now.
Yes, thank you.
Thank you, Councillor Assisting.
Oh.
Commissioners, can you hear me? My name is Amy Munro and I appear on behalf of the Commonwealth. And over the course of the next few days, I will also appear with Mr. Stephen Free, but he's not able to attend today.
Yes, thank you, Ms. Munro.
Thank you, Commissioners.
Panellists, I'm going to ask you to give a brief introductory remark about your organisation and your perspective on the proposals for the improvement of home and community care with which you've been provided. And we'll start with you, Mr. Corley. Mr. Corley, you've made a statement that's at Tender Bundle tab 72, and in addition you've provided a submission and a set of 6 case studies accompanying that submission. We'll ask that the statement be brought up. You can identify it and I'll ask you whether it's true and correct. And then I'll ask you to make those introductory remarks. Operator, tab 72. Mr. Corley, is that the statement you've made for the Royal Commission?
That's correct.
To the best of your knowledge and belief, are its contents true and correct?
Yes.
Commissioner, that's already part of the tender bundle. Mr. Corley, your organisation, Community Options, is a CHSP provider, is that so?
And a home care package provider, yes.
And you're a specialist in care management, I understand, is that right?
The Community Options model is about care management, fund holding and purchasing services on behalf of our clients, yes.
And in addition to care management, how would you describe the services your organisation provides to older Australians?
Well, under the Commonwealth Home Support Program, we provide basically the full menu of in-home support services, assistance in the home maintenance, house cleaning, social support services, and similarly in the home care package area as well. Our model is that we work with our clients, develop a package of care around their support needs, and then implement that with some support staff and with our coordination services.
Thank you. In the case studies that you provided for the Royal Commission, they and your submission are at tabs 25 and 26. You identify a number of challenging cases in which intensive case management was necessary. You also note that case management is no longer funded under CHSP. Is that proving a challenge?
Well, Community Options was established as under the old Home and Community Care program as a case management service with the model of fund holding. And the transition to the Commonwealth Home Support Program, our case management funding was removed, and that's proved very challenging. We've tried to maintain, traditionally we've worked with clients who have complex needs and have difficulties accessing service, and we've tried to continue that. But I guess we've always viewed the removal of case management at that level of service as an error.
What's the single most important reform issue in home and community aged care for your organisation, and what would you ask the commissioners to do about it?
Well, I've just addressed the case management issue. I think it's wrongly targeted at the moment, but I think that the system needs to be made compatible with the wants and aspirations of older Australians, and that is a primary focus of people to continue to live at home for as long as that is practical and appropriate for them, and that should be the policy goal.
Thank you. Mr. St George, you provided a submission that's available in the tender bundle at tab 31. It describes the development of Vitality Club from its origins as a walking group some 5 or 6 years ago, was it? And you've since developed Vitality Club into, if I may say so, it sounds like a dynamic provider of niche services of various kinds. Is it the case that you're primarily funded under CHSP?
Yeah. So we have several contracts. One of them is to deliver CHSP for allied health across all 5 regions of Sydney. And recently we won a growth round to also deliver service in Melbourne and Central Coast. That would be about 70% of our funding. We also deliver regional assessment service assessments for Northern Sydney and Southeast Sydney, as well as being a new home care package provider as of 2019 May. We also run a few contracts for New South Wales Health in the provision of exercise classes across regional communities in Australia, in New South Wales.
Now, you've made some cautionary remarks in your submission about the administrative difficulties of the HCP program. You've cautioned in your submission that there might be difficulties in integrating the program, that is integrating CHSP and HCP, if the expectation is that all of the CHSP services are going to be packaged and marketised in the manner of an HCP package. Is that right? Is that your view? And what are the reasons for these concerns?
Yeah, I think that is a fair summary of my opinion. In my opinion, the home care package system is an effective means of delivering long-term care. However, it is currently struggling under the quantity and caseload provided. So there are about 120,000 people receiving a home care package, with about 100,000 people waiting for a home care package for about 6 to 18 months. The CHSP program is grant funded, but services about 800 to 900,000 people per year. And I find it difficult to imagine a situation where the home care package system can absorb those 900,000 people to deliver seamless care and immediate care for 1.2 million people when they struggle with the current 200,000 people.
From your organisation's perspective, same question I asked Mr. Corley, what's the single most important reform issue, and what should the Royal Commissioners do about it in your opinion?
In my opinion, I personally think that the single assessment workforce is probably the most important reform issue. Merger of ACAT and RAS could go a long way towards seamless delivery of aged care services and a more seamless consumer journey for people who are receiving subsidized care at home. In my opinion, it was politicized due to poor transparency and lack of inclusion of the public health system, which gave it the optics of a privatization bid. Again, just my opinion. But I think that we could go a significant way with a significant increase in an assessment workforce and a more streamlined system through a single assessment workforce by, say, doubling the size of the workforce that delivers assessment and adopting a more preventative model where people get rapid assessment every 3 months to more proactively manage people declining and pick up people before they fall into critical incidences of decline. And it would be great if, when that comes on, Vitality Club can be considered as a prime contractor, as all of those things are ironed out.
Thank you, Mr. St George. Ms. Brower, Meals on Wheels is very famous and well known, but for the record, I'll ask you to just outline what are the services that Meals on Wheels provides, what are the incidental benefits, some of which you've noted in your submissions at tabs 50 and 51, and some of which also are mentioned in the course of your response to the proposals in this hearing at tab 76 of the tender bundle. An outline of the services and benefits Meals on Wheels provides.
Thank you, Council. So Meals on Wheels service model is internationally evidence-based, and it comprises the food, the social support and the wellbeing check on the person that is being visited. In terms of the food, we're providing food to a standard, not a price. We're aiming to deliver about 40% of the daily nutrition requirements in the meals that are provided to people's doors. We're also providing specialty meals for people who have therapeutic dietary requirements or who have swallowing difficulties, so particularly tailored to people who are elderly. Good nutrition is a preventative health measure for older people. We make sure that we provide variety in the diets, and food safety is absolutely essential. The Meals on Wheels service deliverers usually go into the home providing a meal that's hot and ready to eat, or could be chilled or frozen for people to heat later when it's convenient for them to do so. And food intake is monitored, usually visually, but also in discussion with the consumer. The social connection that comes part and parcel with that service is critical to supporting the confidence of people to live independently, and it's a light touch way of reducing loneliness and isolation of people within the community. So the volunteers generally who deliver those meals have conversations with the people that they're visiting, form relationships and rapport with them over time. And that's become quite critical. Many consumers report that the volunteer and the conversation is as important to them as the food that they receive. And then the third part of the service model is the wellbeing monitoring, where volunteers are providing peace of mind and follow-up to family members and others by monitoring how that person's going, asking them how they are and reporting back. And most importantly, following up when people are showing signs of medical distress or indeed may have had a fall, and the volunteers are the first people to be on the scene and get the medical assistance coming in as well. So those are the key components of our service model.
Thank you. And one of your submissions notes that for people aged 85 and over in Australia, Meals on Wheels is providing at least some meals in a given year to about 14% of that cohort. Is that right?
Yes, we do have the median age of the consumers that we support is around 85 years, and data suggests that there's a high level of use of meal services the older people who are living at home, particularly those who live alone.
And those nutritional benefits you mentioned, in the submission, there's reference to studies correlating those nutritional outcomes with improved health outcomes and avoidance of hospitalisations. Is that right?
Indeed. So there's strong evidence to support that good nutrition and nutrition delivered through Meals on Wheels programs has been shown to be preventative of falls. It's also been shown that Meals on Wheels recipients are less likely to present at hospital emergency departments. If they do, they're less likely to be admitted. If they are admitted, their length of stay will be shorter and their recovery and subsequent outcomes will be better than people that are not well nourished on admission.
How are Meals on Wheels funded in Australia? Well, relevantly for present purposes, to the extent that there are aged care subsidies from the Commonwealth, what form of funding are Meals on Wheels services receiving?
Predominantly, the funding comes from consumer contributions. There's secondary funding through the Commonwealth Home Support Program, which is where most of the Meals on Wheels service delivery occurs in Australia. And then many of our members also provide services under contract to home care package providers. So that's an indirect funding stream. We don't receive direct home care package funding. In Meals on Wheels SA, we receive 10%, we deliver 10% of all of the services to the Commonwealth Home Support Program under meal services category, and we receive 5% of the national CHSP funding for that service.
You mentioned in the submission, I think you describe it as a need for that funding to be provided as block funding as opposed to some other form of funding. Would there be a difficulty in Meals on Wheels competing with, say, Uber Eats and so forth via a marketised, individualised package model?
There is a challenge in what consumers perceive is the value proposition of a delivered meal service. So while there is a proliferation of home delivery services in the community, they're not delivering the full level of care that a delivered meal service is able to through the grant-funded activities. Grant funding is particularly suitable for Meals on Wheels services, given that we have high fixed and capital costs associated with the service, along with a reliance on volunteer labour, and also that Meals on Wheels is a service that the community expects to be available immediately. It's an essential human need to be able to access food and to be able to stand up services rapidly, such as we recently were able to do during the pandemic, is one of the benefits of grant funding.
And again, the same question that I've asked Mr. St George and Mr. Corley. What's the single most important reform issue in home and community aged care from the perspective of your organisation? And what would you ask the Royal Commissioners to do about it?
Recognising that good nutrition is fundamental to healthy ageing at home, we need to make it as easy and quick as possible for older people to access the meal and nutrition information and support before they become undernourished. Ensure that people's consumer contributions for meal services are affordable, and improving the interface between primary health and aged care systems. And we believe that can be achieved by providing older Australians with an entitlement to appropriate food services to support their healthy ageing, direct, rapid and simple service access, and equitable, adequate and sustained investment in evidence-based meal support services so that consumers pay only the cost of the ingredients, eliminating the financial barriers they're currently experiencing and improving their health outcomes. And we're very encouraged to see that these matters are largely addressed in the draft propositions.
Mr. Voukalatos and Ms. Attridge, if it's all right, I'll address you jointly, and I understand you're going to have some sort of method of deciding who responds to a particular question I pose to the uniting organisations that you represent. Could we have a brief outline? I know the operations of the uniting entities are very extensive. Taken together, we're probably talking about certainly one of Australia's very largest providers of aged care in the home and community, could we have a brief outline of the scale and scope of the operations in home and community care subsidised by the Commonwealth aged care system?
Fonda.
Good morning, Mr. Gray, and good morning, Commissioners. My name's Fonda Galados, and I'm representing Uniting Care Australia and Uniting Age Well. In terms of the size and scale of services for Uniting Care Australia, we're talking about having in aged care over $2 billion worth of services funded through various means, including residential aged care, home care packages and CHSP. From a home care package perspective nationally, we're delivering over 15,000 home care packages as a collective. My organisation, Uniting Age Well, that operates across Victoria and Tasmania, delivers approximately 1,800 home care packages. In Jackie's situation, Uniting New South Wales ACT delivers over 2,200 home care packages per annum. So we are a very, very large entity, but we're also quite big within our own catchments as well, Mr. Gray.
And in addition to home care packages, are the Uniting organisations providing services funded by CHSP?
Absolutely. So the Uniting entities all provide CHSP services in the home, centre-based activities, allied therapy services. We also provide flexible care under the Aged Care Act. That includes initiatives like short-term restorative care and transition care programs in the community.
And across all those different modes of care and support, would it be fair to say that there is a range of different modes of engagement of the people who provide the care directly, so that you've got permanent employees, you've got casual employees, you have specialists whom you might subcontract? Is that a fair summary?
It is a fair summary, yes. All of the above, Mr. Gray, yes.
Yep. And this might be difficult given the breadth of the organisation, but are you able to say, Mr. Vikalatos, what is the most pressing reform issue of all in the home and community care sphere, and what should the Royal Commissioners do about it?
Yep. So probably the largest reform issue that we're facing is the suitability of a current home care system to deal with unmet needs, deliver high quality, coordinated, safe and responsive services to each person at the right place at the right time. Simply put, how do we go about having the biggest and best impact we can in the health and wellness of people, given the current fragmentation of the system, the supply issues and current funding arrangements?
Thank you. Well, that's a good entry point into a theme that I want to test with this panel now. The theme is the challenges of integration of CHSP and HCP, how best to transition the current arrangements into ones that are easy to use, efficient, and can deliver care that meets principles of autonomy while also balancing autonomy with safety and facilitating flexible but strong care management, particularly where people have complex needs and they need intensive care management. Now, can we break this into separate propositions, and I'll ask the panel some questions about each. Involved in, as a sort of a background to the questions I'm asking, it should be understood that you've read the outline of new service arrangements that was furnished to you, as well as the propositions document. Both of those documents are in the tender bundle and available to the public. Firstly, propositions HC1 and 2, which envisage a transition to reformed arrangements for demand-driven uncapped care in the community and in the home, with the recipient able to choose to receive home care funding up to a level equal to the care component of the funding that they would have received in Resi Care. Could we just take that principle first? Could I ask you, Ms. Attridge or Mr. Voukalatos, to comment on whether you agree with that as an optimal approach to reform of the system?
Yeah, I think understanding what the unmet need is within home care is critical in terms of it being successful, and then having a system that has the capacity then to respond to that need regardless of where someone lives. So we would absolutely support that proposition.
Yeah, and are there any other panellists who wish to offer a different view or an additional view to that view of Ms. Attridge on that element of these proposals? No. Thank you. We'll move to one of the interim measures, which is in HC1. Firstly, under the existing arrangements whereby we do have still separate programs, home care package and CHSP, the first interim step is to clear the waiting list for assessed need for home care packages and keep it clear. No doubt that will require additional funding, but also to rearrange services to this extent to allow people on packages to access CHSP for certain categories of services corresponding to social support, respite and the like, in accordance with the proposition we've provided to you. Now, Ms. Brower, can I ask you, what's your response to that element of these proposals?
I'm unclear as to whether the intent is for the package funds to pay for the services or the Commonwealth Home Support Program.
Yes. The proposal is for the Commonwealth Home Support Program to make those services available.
Right. In that case, the concern that I would have is an avoidance of oversubscribing the Commonwealth Home Support Program. We need to ensure that people who don't currently have needs requiring a home care package can also continue to have readily available access to those services. We would want to make sure also that some of the discrepancies in consumer contributions to the programs are made clear. So currently, certainly for my service at Meals on Wheels SA, a consumer receiving a meal service through a home care package pays only the cost of the ingredients in the food, which is $4.75. They also make a contribution, a means tested contribution to their total package, which I understand from the Aged Care Financing Authority reports is around about 6%. Within the Commonwealth Home Support Program, the level of government investment is much lower, and it's quite variable within the CHSP, within and across jurisdictions. So again, in South Australia, Meals on Wheels service delivered to the CHSP requires a consumer contribution of $9.75. So it's the exact same service, but the consumer's paying $5 more to get that service through the CHSP than through the home care package. So for this proposition to be successful, there'd need to be not only an increase in the capacity of the CHSP to respond to those 100,000 people who are on the waiting list, some of whom may indeed already be receiving meal services from the home support program, but we also need that evening out of the government contribution so that it's completely transparent and understandable to the consumers about what they're accessing. Having said that, I think there are some strengths in being able to access social support, respite, transport and meals as Commonwealth Home Support Program services outside of the envelope of the funding of the home care package budget. I think it would be administratively simpler and more straightforward for service users.
Thank you. Mr. Cooley, broadening out the discussion to encompass not just meals, but those other categories of services, transport and other social support services, respite and the like, which Ms. Brower touched on at the end. Do you consider that if those two conditions are met, which Ms. Brower identified, upscaling the capacity of the grant agreements and the activity limits, no doubt, on the grant agreements under CHSP, and equalising and creating uniformity as to co-contributions, if those two things are done, then this transitional mechanism is workable? What are your views, Mr. Corley?
I think there are issues in the transition. I broadly support the transition to a more unified funding stream for aged care. I think there can be a variety of service models under that. As a CHSP provider, we're already under increasing pressure from home care package providers seeking our CHSP services to effectively top up their packages. And I think that needs to be carefully monitored because, you know, a significant proportion of the people currently waiting for a home care package would be receiving CHSP services. And if those services are no longer available, a significant portion of those people would find themselves in extreme difficulty. But as a transition arrangement, I think it could work if it was carefully managed and planned, yes.
Carefully managed and planned by a very active system management function on the part of government, keeping a very close eye on local developments. Is that what you
I think by government, but also regionally, because I think regional variances will occur. And I think that you would, in that transition process, you would require a significant injection of funds, probably at both levels, but to allow that smooth transition, because what you don't want is people being falling or not being able to access CHSP during that transition because all those funds are being directed to supplementing home care packages.
In your opinion, does government have its eyes on the ground to the sufficient level required on a regional basis?
No, I think I would strongly urge government to re-look at regional planning models for aged care services. I think a lot of the decision making is centralised. Even state officers aren't necessarily involved in making decisions, as we understand it, about funding or things like that. So I would strongly urge a regional focus involving local health authorities, involving local providers, involving local communities as much as possible.
And would that local level gaze or regional level gaze also be a necessary precondition of a successful transition, Mr. Corley?
I think it would be an indicator or something that would enhance a transition, absolutely. I mean, I think regional differences should be allowed to grow and develop. I don't think we should aim for a homogenised system where everything's the same. I think regional development, regional initiatives, we can all learn from those.
I want to move to another topic, but just in case any of the other panellists had a brief contribution, particularly if you disagree with something that's been said or you have a critical addition to make.
I just think it's worth noting that the original intent of the Commonwealth Home Care Package of the CHSP program was about entry level. What you're proposing now is looking at service types that would go across the need journey of the client. I think that for some providers would be a significant change in terms of what the intent of the original CHSP program was. So that would need to be worked in terms of how that would transition. I think Fonda's wants to say something too, but also too, just acknowledging the fact that you need to have a coordinated approach to services as well. There's complexity when additional and multiple service providers are involved in the provision of care. So there would need to be clear ways about how those different providers could potentially coordinate as well, I would suggest.
Mr. Verglatter, sorry, I think I'd better move to the next topic, unless Mr. St George, on behalf of his organisation, has a contribution to this point.
Yeah, I'll just try and be quick. Firstly, with the transition, continuing CHSP funding for a narrower scope of organisations to deliver a service is fine. However, moving to a package set of funding for care at home, as you've suggested, could be a difficult transition especially when it could require significant upskilling of an assessment workforce to determine the package needs and the level of contribution that people should be able to get based on their level of, let's say, disability or frailty. And that could be a significant change. I think underpinning it all would be reasonable to implement a sort of single source of truth, a risk stratified care plan for consumers that all people use as a coordination point before they deliver care, and they update and modify this sort of situation. It would be difficult to transition, in my opinion, just based on the volume of people. But I think that without a mix of grant funding and package funding, the system could still fall into the same gap of people, let's say, double dipping or not knowing where the bounds of scope to accessing their services lie.
Thank you, Mr. St George. Just for those viewing the evidence, Mr. St George's submission at tab 31 expands on the idea of the risk stratified care plan, and that's intended to be a single tool which will be accessible to all people providing care, Mr. St George, and be capable of being updated by all people contributing to the care of a particular individual over their entire journey and use of all of the services that are available. Is that a correct summary?
Yeah, I think it would be a good building block to be able to follow a person through their journey of receiving services and really assist all providers with managing multiple stakeholders in the delivery of care.
I want to go back to the response Ms. Attridge gave and use that to open the next topic. Ms. Attridge, you correctly pointed out that there is quite a fundamental restructuring involved in these proposals, whereas the present arrangements are conceived of on the basis, it's supposed, of entry-level services via CHSP and more advanced or complex services via HCP. In fact, that's led to, in our submission, confusion and fragmentation, different assessment processes, as Mr. St George identified, RAS and ACAT for the two, even though CHSP is used very substantially to help people who are assessed as needing an HCP, and there's in effect the same categories of services available under CHSP as are available under HCP. It's just that under CHSP they're supposed to be time limited. This restructuring is on a service category basis in the hope that that will be clearer and that one assessment service can be used to give access to the whole suite of available service types. But important to that, our proposal is that the first three categories of services, which include social supports as we've defined them, assistive technologies and home modifications, and also respite, will be grant funded or block and activity funded by direct agreements with providers. All care at home, where there's a sufficient market for a package to be used, will be funded via an individualised package. I want to now turn to that point. That is where these proposals lead. That is what we transition to on the submissions that we're advancing. What are your responses to that proposal? I'll start with Uniting. Does Uniting want to comment, either Ms. Attridge or Mr. Virgulatis?
Thank you, Mr. Gray. So Uniting's response to this proposition is that we need to move to a fully accessible, more simplified system that actually builds on the strengths of individuals. So the domains that have been proposed, we're in agreement with those, and we believe that as people's needs change over time, that they should move to an individual program. In addition, people who are entering the system for the first time may have complex care needs. So they, of course, need to move into that care management individualised package component as well. We feel that every Australian, as per our submission, needs to have access to good care regardless of where they live in Australia.
Mr. Cooley, can I turn to you? And in particular, I'd ask you to comment on what you think of the proposal that is critical, that is a critical element to this overall suggestion, that is that there be a budget for care management per se on the basis of an assessment of the complexity of the care management needs of the individual.
I'm broadly supportive of the establishment of a budget, but one of the issues of concern is that care management sometimes is required as the person enters the system because of their complexity. And so a problem arises where they don't get care management until they get a budget assigned. But for some people, it's navigating that process, it's some of it, and it's the negotiation and solving some of the complexities around their support needs that has to happen up front. So there needs to be some capacity to support people even entering and maintaining themselves within the support system, because some highly vulnerable people drop out of support for a whole variety of reasons. So care management / case management, whatever you want to call it, can happen be required at multiple points. And I think the other element that needs to be considered is often care management is defined by providers as just managing what they do. And I think we need to look at care management or case management in a broader context of helping vulnerable older Australians to continue to live in their homes and interacting and interfacing with all services that may be involved, both aged care services and other that may support or put that at risk. So there's a broader context of care management that needs to be considered, and there needs to be capacity for it to be, if you like, front-ended as people are trying to enter the system.
Mr. Cooley, as you spoke, I was reminded of the second of the case studies that you have documented and lodged with the Royal Commission, which is available in the tender bundle. It ostensibly was a case of providing cleaning services for a person who actually had a whole suite of far more complex needs. It was a salutary reminder that you can't make any assumption just by reference to the fact that a service might be described in simple terms, that the case is at all simple.
Sorry, Councillor. This is one of the things that people often get, confused about, that someone's just getting domestic assistance or another low-level service or even an entry-level service. Sometimes for some of our clients, those are the hardest services to sustain, and those are the only services people will accept, even though they might be assessed as needing a wider menu.
Mr. Cooley, the proposal here is to have these service categories, but none of them really should be described as an entry-level service. They're all flexible according to need. Would you agree that that is the right approach?
I absolutely agree. I've never subscribed to the conveyor belt model of aged care that you enter at one point, move through to another system, and then move into finish up in residential aged care. That, as you know, the data doesn't support that. That's not the experience for most Australians using the aged care system. So every service that a person receives at whatever point is crucial to their needs at that time, and should be adjusted as their needs change.
And I should make it clear to those listening that our proposals, as we've documented them, are that services from these categories might well be available at the same time to the same person. There is in no sense any mutual exclusivity between the service categories. And would you agree, Mr. Cooley, that that's the correct approach as well?
I do agree that it's the correct approach. The only comment I would make about the in-home services is that I believe I don't fully support that it's all individualised. I think there needs to be a safety net, and I think there needs to be a capacity for quick response while some of those assessments are taking place. Because our experience in the National Disability Insurance Scheme is you're either in or you're out. If you're not in, there's nothing for you, and that's can be hugely problematic. So I'd encourage the consideration of some quick response, safety net services that can provide support while some of these other things are taking place.
So how would that look? Would that require local or regional commissioning by direct grant of a service provider of last resort, so-called?
Quite possibly. I think it would vary on region to region, and you know what we all know in some of the rural and remote areas there will be a scarcity of service providers, so there may be some individualised commissioning there. I just think it's the issue is that people's needs. People sometimes enter the system quickly. You know, their health condition changes dramatically, and they need services. Or we often get calls on a Friday afternoon for services to go in on Monday, or their primary carer has a fall or gets ill, and they need services immediately. So I just think a system needs to have capacity to respond to those rapid changing circumstances.
Thank you. Can I open this up to any other panellists who wish to either disagree or add to what's been said on this important topic? Yes, Ms. Brower.
Thank you. We really support the notion that meals, community transport and social support are included in a discrete category, and that category is grant funded, and it's because those services are often bundled together to create a social connection experience for older people. They can be high frequency, low intensity, relatively low risk services, and are sometimes required episodically. And I'd like to reinforce the point that Mr. Corley made about some services needing to be available very rapidly, even before a comprehensive assessment of somebody's needs are done, particularly to support hospital discharge or hospital avoidance. And further to that, if people do first come into contact with the formal aged care system at a point of crisis or instability, that the presenting issues that they have at that point need some support and case management. And it may be that within a fairly short period of time and some stability comes into play, that they may not need such an intensive set of services in an ongoing capacity.
The proposals we've documented and provided to you include obviously a much bigger and more nimble assessment capability than currently exists. That's the first thing. And also a person who would act as an intermediary between the assessment service and the person who's seeking the services, whom we've described as a care finder. Do you agree that those are sensible propositions? Do you think they're workable?
Yes, I do. And I think that the care finder may be able to access immediate services, whether it's from commissioned providers or some other mechanism, but that may be the mechanism that would support the proposition being successful.
I want to go to the next topic now. It's a brief one. It's HC6F, and it's the starting point to determining where it might be necessary to commission services or to take other steps to supplement supply of services, particularly in rural and remote areas, possibly also in metropolitan areas for diverse needs groups. If supply is thin or scarce in respect of the needs of particular people of diverse background. Do you, the panellists, agree that it would be sensible to obtain a much better understanding, and this must be done by or on behalf of the government, of where the gaps are in the services that provide CHSP and HCP services are present and on which this future system is going to depend? Start with you, Mr. St. George. Do you agree that's a sensible step?
Yeah, I think that in a primarily government-funded industry, the ability to undertake market analysis and identify gaps is always paramount. I think that currently the government utilizes CHSP growth rounds to target areas of need where they oversee the sort of data that is put into the data exchange, which is where CHSP providers report their outputs, in order to target certain areas that might be underserviced. As far as I'm aware, home care providers don't need to report on output level data like that. And that could make it more complicated for the government to be able to do that type of market analysis. But ultimately, all of these things only really capture the known need. And I would suggest that there is a far greater level of unknown need that exists in the community from people who have trouble accessing the system, who don't necessarily have like some kind of financial disadvantage, or being able to equitably access the system. And that could require a more thorough needs analysis on a region by region basis. Yeah, I think that's...
Yep, thank you. Do any of the other panelists wish to add to what's been said? I'll move on to another topic if not. Thank you. There's a question about whether the funding that is provided in packaged form is actually sufficient to or well calibrated to assess need. At present, there are four, my words, somewhat arbitrary levels of home care package. You'll see that in the submissions that were made to the Royal Commissioners in March, there's a proposal that there be independent price analysis, independent cost analysis and the calibration of funding levels to actual cost data. And in the forthcoming hearing in mid-September, there'll be greater development of this concept. Now, built into the funding provided to meet individually assessed needs, is it uncontroversial that the funding should cover the sorts of on-costs referred to in our proposition HC4, capacity building, training, and other necessary overheads? I'll start with the uniting.
Yeah, absolutely. All of what you're talking about there are core parts and requirements of providing a safe, quality service. So, yes.
Yep. Do any other panelists wish to comment on this? Ms. Brower.
Yes, there's been a lack of rigour and transparency about the efficient cost of care of people in the home. The Commonwealth Home Support Program process for price setting is a mystery to many of us. The future price setting process must be transparent and fair. In addition to the on-costs that have been listed, capital and fixed costs also apply to many of the services that are delivered in people's homes, especially meals and transport and respite, but also to some other categories. And those services that have been reliant on a volunteer workforce have been somewhat disadvantaged over time with the way that the pricing has been set. Only the volunteers' time is free. Every other cost of engaging volunteers is the same as if it were a paid worker.
Thank you, Ms. Brower. Does anybody? Yes, Mr. St. George.
Yeah, look, I wholeheartedly agree with the fact that pricing should account for all sorts of administrative and case management activities, and the things that you've listed are all core inputs to that pricing.
Can I just stop you for a minute? We do propose that care management receive a separate budget. Yes, I'm sorry. Please go on.
Sorry, but yeah. So just initial and ongoing education and improved management and governance, all of those things are very important to price into the cost of doing business. I do, however, think that there should be a much greater increase in pricing transparency around these costs in order to really ascertain what the true value of these costs are to each organization. For example, our organization is much more lean and we're able to do things slightly cheaper than, say, Uniting, who cover the breadth of Australia. And those things have to form the matrix of adequate pricing. But it always seems to be a race to the bottom. And when we price these things in, we have to understand that we're pricing quality. And so we should account for the fact that if we improve the funding into these areas, organizations will have more breadth and more scope in order to really invest in these activities, which can overall improve the quality of services offered throughout the industry. And so it shouldn't really be around finding out what the lowest common denominator is, but really what the lowest common standard of care we're willing to accept is, and how all organizations need to work together in terms of resourcing and funding to achieve that standard.
Thank you. Mr. St George, were your remarks then directed specifically to one or other of the current forms of funding, that is CHSP grant funding or HCP packaged funding, or were they generally applicable to both?
I think they're generally applicable to both. However, I was probably leaning more towards the home care package funding arrangements as they stand. But there is like significant lack of price transparency around CHSP services. But yeah, home care package services are probably more of a problem area, especially with regards to consumer expectations and consumer knowledge about what the industry pricing regimes are.
Do any other panellists want to comment, including on Mr. St George's additional point there that in any future transparent cost review and subsidy level determination process, it will be very important to in effect price in the quality that the system is seeking. Does anybody wish to respond, or I'll move on to the next topic? Mr. Corley.
Well, other than just to agree, you have to price it. If you want high quality, you've got to price that in. There's no other way around it.
Yeah. Can we go now to a topic that I raised right at the outset with you, Mr. Corley, so we might as well carry on with you. We've got two developed propositions about care management, HC5 and HC10. There's also HC3, which is a proposal to reposition self-management for people for whom it's appropriate and they wish to manage their own care and support arrangements, to reposition that or reorient that as shared management of care. So these three propositions, HC3, 5 and 10, are all critical to proposals about how care management should operate. And I'll just paraphrase briefly. HC5 is intended to impose a very strong care management responsibility on any home care provider who is hosting a person's home care package. And that, when I say a home care package, I mean a future package for care in the home under the fourth category of services. And as I said a couple of times earlier in this session, there'll be a separate budget, an estimate of hours. The assessment process will actually focus on the complexity of need of the individual who's seeking the help, and there'll be a good deal of attention given to what the care management requirements are, who should be, whether the person providing care management should be clinically qualified, who should be providing the care management. If the needs are complex and clinical, then the care management should be by a clinically qualified person. And that there's a very close link here to assessment. Assessment in HC10 has to get this process right from the beginning, and it must approach this issue with an enablement perspective from the outset. Now, I'm sorry that was a very long lead up, but Mr. Corley, starting with you, have we got it right on care management?
Well, the implementation is always the issue. I'll just make some observations. Care management or case management, whatever it is an important service if it's directed correctly to people who need it. If it's not directed to people who need it, it's a waste of time. in our current system, many people in their home care packages will be paying for case management and not getting it. So the targeting of care management is fundamental. And what that means is those people who are assessed or it's determined they need some sort of care management or case management support, then that needs to be adequately funded to do the task at hand. And that could be short term or it could be long term. It just depends on the circumstances, or it could be periodic, if you know what I mean. People fall in and out of situations. So the targeting of care management is important. It's a valid and vital service for those who need it. It should be appropriately supported and delivered by qualified and trained staff. And it should be done in partnership with the person, not in control. I like your notion of shared responsibility, but the care manager needs to be clearly working for the person. I know there's some criticism about the potential for care management to channel people into certain providers and things like that, and that needs to be guarded against. The care manager needs to be clearly working for the person, but care management should also be closely located with service, because the care manager needs to exercise control over the services, be able to negotiate with different service providers to get the outcome that's required for the person. So it's a complex issue. Suffice to say, I think it's a step in the right direction. It's important that it's recognised. How it's funded is important. Our experience in the NDIS is it's badly targeted and underfunded, and people who need lots of support coordination in that world get not enough, and some people who don't need it get a lot. And so there's balance that needs to be applied here, but it's fundamental that it's recognised as important and it's targeted appropriately. Would be my comment.
Thank you. And Mr. Cawley, perhaps you were thinking, when you referred to the NDIS experience just then, perhaps you were thinking of Mr. David Toon's review amongst other evidence of problems in the NDIS sphere with support planning and support coordination because of resourcing and timing issues. Is that what you had in mind there?
Well, certainly on our experience, being funded for 15 hours a year to provide support coordination to a person with complex support needs is woefully inadequate. And that causes real issues, and it causes providers like ourselves to do vast amounts of effectively pro bono work for the National Disability Insurance Scheme.
So there are some preconditions to this proposal being successful, and I
think the precondition is that it's recognised as being fundamentally important, and it's appropriately targeted and then appropriately funded.
Yeah, and it sounds like it also needs to be supported by a very well-resourced and nimble assessment function. Is that right? Because of the changing needs you just mentioned. A person might not need care management for a time, then they might need it temporarily, or they might need a great deal of it, or the amount they need might change. All of that needs nimble.
They're the variables that as people move, interact with the system and other issues occur. I like the concept of a nimble assessment. Again, some of the issues that all providers face, and again, if we're looking at the National Disability Insurance Scheme as an example of people waiting several months for a reassessment when their needs change, and that again causes huge problems. So nimble assessment is important, but also the capacity of providers to respond quickly.
Yep.
While waiting for that assessment or reassessment to occur is important. I guess that's going back to an earlier point I made.
Can I open that up to the other panellists? Can I ask, uniting either Ms. Attridge or Mr. Voukalaspos, do you have any comments to make? Do you disagree with anything Mr. Cawley said? Do you want to add anything?
Oh, we've lost.
I can't hear Ms. Attridge.
Can you hear me now?
Yes.
Yeah, apologies. I just listening to Mr. Cawley, I just wonder about the underlying issue of supply, whether it be about making sure that funding is available that's appropriate to people's needs, so we're not foregoing one service type for another service type too. I think we see that a lot, and responding to that underlying issue of supply, I think in the industry at the moment will be one that will help significantly.
Thank you. Mr. St George.
Yeah, I would like to just say that in a proposed single assessment workforce where the assessment workforce would not need to be separated by RAS and ACAT, organizations that are selected to deliver this service would have the ability to sort of clinically triage complex cases and then deliver these plans. I think that it makes sense as an extension of this service. So they have, let's say, a mobile or a rapid response team to be able to deliver short-term case management or, sort of like a program of reablement care in order to make sure that by the time that services are implemented by normal providers, that person hasn't deteriorated further. I do accept that there is a significant problem in care coordination in the system and with people being lost in the system. So they go, they have an assessment, they wait for services, they wait for an ACAT assessment. And it is my hope that with a single assessment workforce that can be alleviated to some degree. But it would be nice if there weren't additional links in that chain for people to have to go through in order to receive that sort of continuum of care. If that was handled by the assessment workforce, which inevitably things will have to go backwards and forwards through anyway, I think that could be a more seamless journey for a client going through the aged care system. And I think that in a single assessment workforce where organizations are required to have that capacity for clinical triage, if they could expand that team, that is a sort of service that they could offer.
Thank you. I want to go now finally to a topic that Ms. Attridge mentioned in her response a minute ago, the question of supply. And Ms. Attridge, I'll start with you. It's the theme of building the capability of providers and the workforce to meet the challenge posed by the set of arrangements that we are proposing. That set of arrangements, just to repeat myself perhaps, deals with a vast spectrum of need for a little over 1 million people going on the current numbers of people in CHSP and HCP programs. And their needs vary from quite simple needs to the most complex imaginable needs for a person seeking to remain at home. And we've explored some of the arrangements that might facilitate an ambitious integrated program covering that spectrum of need, but we haven't focused on the capabilities of the providers and the workforce and what will be needed to ensure that we can transition to a system of that ambitious scale and scope. So starting with you, Ms. Attridge, what are the things that can be done? I'm not asking for hard data. I'm not asking for an estimate of how long it will take. But what are the things that can be done to ensure that providers and the workforce have the capability needed? We know that there's a set of strategic actions recommended by Professor Pillaire's group. And it's the position of those assisting the Royal Commissioners that those actions should be taken to improve the workforce. Do you agree with that? Is that a reasonable starting point? And what other measures should be taken?
Well, firstly, I'm not over Pillaire's responses, so I can't talk to those. Just from my personal experience, though, I think what we need to do is make home care and aged care more generally an attractive place to work so that we can attract and retain the types of people and the quality of the workforce that we need to respond to the underlying need that we know is there. We already have challenges in terms of recruitment now and competing with public health systems, but things like conditions and pay and the like, and supports more generally need to be there so that we can have the volume of people that we need to deliver the types of services we want to.
The propositions that we've developed for consideration by the Royal Commissioners in effect seek to incentivise a direct employment model as the predominant model through which care would be provided. And they also float the idea of a minimum Certificate 3 qualification, at least for people who are performing unsupervised hands-on personal care work in the home. There's also an element of a minimum hours requirement or a minimum contact time requirement so that we don't have rushed task-based care delivery. Are these things good ideas? Are they too inflexible? What are your views on those measures?
So in relation to the first two, absolutely. So for Uniting New South Wales ACT, we already have in place that all of our care delivery is delivered by a minimum of a Cert 3 worker, and the vast majority of what we do is delivered by a direct workforce. Not suggesting that different models can't work, because I know that they do, and I know that Community Options in particular use a contracted model. From our experience in terms of monitoring and checking and the quality of the care, that is far simpler when you're employing the staff directly. They have access to your systems, to your care plans and the like. That's much more simpler. They are aware of your policies and your training programs. So we would absolutely agree that the direct care makes sense. The minimum hours, I think it depends, as long as it's proportionate to what's being delivered, I guess. Sometimes clients don't want you there for a long time. I think it's more about understanding what the requests and the requirements of the client are. And again, going back to that capacity and having the capacity to respond to the need is the important underlying piece there.
Mr. Cooley, can we go to you? Community Options has just been mentioned.
Yeah. We, when the Community Options system was introduced into Australia in 1990, it was done based on a fund holding and service purchasing model, and we still operate under that model. Like all things, it has its advantages and it has its disadvantages. I certainly wouldn't argue that subcontracting across the whole system should be widespread, but it allows a certain flexibility and allows a certain nimbleness for us to reallocate resources, change providers, change workers when that's in the best interest or at the request of our client. And as some of our providers that we use know, we'll just ring up and say, never send that worker to that person's house again. The benefit for us is that's not our HR problem, that's the provider's HR problem, but we can make that decision quickly. And we do that from time to time when a client reports something or is unhappy with a worker. So I understand the basis of the proposal. I think there are huge issues generally with the casualisation of the workforce, but I guess I'd argue, as I have previously, there needs to be some flexibility and some capacity for different approaches to work in any dynamic system.
And Mr. Cooley, just a point of clarification, when Community Options subcontracts a provider, and it is very largely a model in which Community Options does that, as I understand it. Firstly, is that correct?
Yes.
Yep. And do you know whether the subcontracted provider is deploying a workforce that is directly employed by it?
That's a requirement. We contract all of our providers, and we have our own quality assurance program. And in certainly the agreement that they sign with us, they're not allowed to they must deploy their own employees. They can't further subcontract the worker. The other element of our model is we take full responsibility for the service. Yeah.
Thank you, Commissioner Briggs.
Yes, thank you. If I might just follow that up. Do you get from those subcontracted providers information about the training and qualifications that they then invest in their workers?
That's part of our annual audit process. We audit each of our, and as I said in my submission, that's been delayed this year because of COVID, we haven't done our regular schedule of provider audits, but we audit our providers on an annual basis as a minimum. Sometimes we'll audit them more regularly if issues emerge. But they need to demonstrate to us, the provider, the training they provide their workers. We mostly use approved aged care providers in this town. We use some commercial providers, but most of the providers we use are aged care providers, and we work closely with them. We sometimes choose, and we get to know individual workers with individual agencies, and we will go to a provider and ask for specific workers from time to time. But yes, we audit them for training, we audit them for quality assurance processes, and all of those, and police checks, etc.
Mr. St George, is a direct employment model needed to ensure quality and safety, that appropriate training and supervision's in place, or is that inflexible?
Look, as Jacqueline said, I think that direct employment is significantly easier to control. It's significantly easier to train and ensure quality. And in terms of incident reporting, complaints management and stuff, is also significantly more streamlined through direct employment. With subcontractors, it's very difficult to know, to get them to deliver a model of care as opposed to just a service. And I think that as the aged care system develops, that's what needs to happen. I think it's impossible for the aged care system to exist solely on direct employment, just due to the scope and the breadth of the amount of clients and the amount of people requiring care, and the breadth of, say, a complex care plan requiring so many different services. Especially smaller organizations would really struggle to have direct staff in all of those different types of services in order to facilitate that whole care plan. If I may, I might just touch on some of an earlier question you asked, which was what can we do directly now to sort of improve workforce capacity? And I would, again, just agree with Jacqueline and the things she said. I think one of the key points is people need to come into the sector and be retained, and competing with the hospital sector where people have a more significant level of clinical attainment, or the disability sector where people are seen as like specialist skills, both with greater levels of remuneration than the community sector, is a significant structural problem. I think that the workforce shortages that are projected are a significant structural problem, which will mean that there will always be supply side shortfalls. And in order to overcome those supply side shortfalls, we need certain innovative solutions. One I would suggest would be adopting like an e-health record that is basically able to facilitate communication between all stakeholders. Another one I would say, like with a projected shortfall of, say, allied health and nursing staff of 220,000 in the next 5 years, we would probably need some kind of net migration solution to open up skilled migration in for those jobs. And finally, I think training also needs to be more targeted and more streamlined in terms of the holistic client journey. I think we could make significant strides as an industry if everyone like told the same story to the client about where they are in the aged care journey and how they're going to progress and what could happen. And I think that training or that direction should come from the government. And they should say, like, this is how we want all organizations to talk about the aged care system, so there is less consumer dissatisfaction or consumer confusion around where they are and what's happening in the system. I think that could make a significant difference to people's experience as they go through the system. And even with the fact that they may be waiting, or they may not be receiving services like to their assessed level, all of that could be streamlined into a more holistic conversation that all providers are able to have on the same footing.
Thank you. Just finally, for the other panelists, I take it from Mr. St George's response just then that the idea of an e-health record or I think you called it the stratified risk-based care plan, this is not something that Mr. St George's organisation currently has available in digital form to share with the providers with whom his organisation brokers services. Is that correct, Mr. St George? It's something that you think should be in place, but it's not yet in place.
Yeah, very aspirational.
Yeah, what is the capacity of the other providers who are on this panel at present to move to technology of that kind? Is it in the pipeline? Do you have anything resembling it now? Mr. Cooley, does Community Options have a digital platform of some kind, a business-to-business record-keeping system through which it can
not
maintain
currently.
a plan and
We have
share it?
we probably have one in the pipeline. One of our software providers working on is on an integrated platform that providers that we use could also access, but we're probably some way away from that at this point in time.
And Ms. Breyer, with Meals on Wheels, I understand that the Meals on Wheels volunteers and employees do make reports in relation to their impressions of people's needs when people are receiving services from Meals on Wheels. Is that in effect an IT system within Meals on Wheels, or is it shared more broadly?
No, each service would have its own digital platform. I think the intent of the My Aged Care service provider portal was to give some visibility over the service plan for people. I don't think that's working at the level that it could, and certainly not as described by Mr. St George. So I think there would be some opportunity for development in that area. Meals on Wheels currently would have a fairly manual process of identifying an issue and then making telephone calls to family carers, GPs or others involved in a person's care if issues or concerns arose, and similarly do now with home care package providers with whom for whom we deliver services under brokered arrangements.
I see. And finally uniting, what's the state of the information communication technology relating to sharing plans across the organisation, or sharing plans with services with whom Uniting has to interact in order to holistically care for clients of Uniting?
So, Mr. Gray, maybe I could respond to that initially. So, the Uniting Care approach and model is to develop with a participant, and for the participant to develop what I call a shared care plan with a goal-directed care plan that looks at a range of different service types that need to interact together. Now, the role of a care manager or case manager is to actually bring those services together and to have that documented in one place for the participant to actually understand what their care requirements are and how those services interact. We have obviously a client information management system, as every organisation does in this room. Does it extend to broader organisations, business to business? No. Can it? It's been a question that's been asked over the last 15, 20 years. What does integration look like on that front? And for that to happen, there needs to be suitable portals and investment made by providers, but also by government in particular, to ensure that there is a more sophisticated electronic record-keeping system beyond what we have at My Aged Care.
Thank you, Mr. Viglaitis. Commissioner, if that's a convenient time, that concludes the most pressing questions I wish to raise with this panel, and I'd seek to have them excused.
Yes, thank you. Commissioner Briggs, do you have any further questions you'd like to
I do. Thank you, Commissioner Pagoni. Thank you, everybody, for the contributions so far. I found it a very helpful session. I'd like to pick up a bit more this issue about the workforce and its development. And I suppose there are two parts to my question. Firstly, what do you do now in terms of the development of your workforce? And in the future, how would you see the task of upskilling and reorienting the workforce to be more proactive around a people-centred system in the future? So over to you. Whoever wants to contribute, please kick off.
I'll jump in.
St. George. Yeah.
Sure.
So at the moment, we have a multidisciplinary team meeting every 6 weeks with our allied health staff. We look through sort of case studies, incidents, reports, and we talk about how we are applying the philosophy of wellness and reablement into the delivery of all the services that we have. We also do organizational training probably every month or every 6 weeks as well, in order to continually hammer in the philosophy of wellness and reablement and consumer-directed care as a journey that we're on as an organization, that we are continually evolving the service delivery that we use in order to deliver better service. It is sort of about 5 years ago when I came in to the aged care industry, I noticed that the community sector was very underdeveloped. There was a lot of fragmentation and there was a lot of services that weren't really communicating well with each other, and the overarching philosophy guiding the industry was met with sweeping changes. I think over the last 5 years or 6 years, those changes have been implemented progressively by all organizations, and they are beginning to show seeds. However, everyone is just at the beginning of that journey. And that is understanding that there is a concept of which they're delivering service, but the implementation in which they do that and how they do that, and then the effectiveness of outcome measurements, I would say is still at a very virginal state in the industry. I think that with the community sector being underdeveloped, it is very difficult to provide our staff with like career progression in a structured environment, something that the hospital is very, very good at. You know, you would go in and you would work your way up certain different levels of expertise, and you would experience a range of more like specialized people training you. With an underdeveloped system, that's not something that we can provide yet. But it would be good to recognize the importance of the preventative model of care in the community sector in order for government to create those pathways for all staff who engage in the community sector, so that they can see that being in the community is not a transient step towards going to acute care or going to disability care, but it has a progression, and the things you learn about are not just for the job, they fit an industry. And when people adopt that identity of being a community sector worker, and they own the fact that they can manage people's chronic diseases, help them adopt lifestyle changes in order to be more independent at home and have more wellness and like quality of life with what they do, then we will be able to see a more sustainable retention in the industry. However, I would say that with the state of where things are, while they've improved, it's difficult to create that vision with the infrastructure that we have. And and so we basically have to make it up.
Yes.
Mr. Corley.
Thank you, Commissioner. A person-centred service happens at the point of service. That's the primary. You know, we can have organisations can claim they're person-centred and have great policies, and that's fine, but it's at the point of service. And the greatest complaint we get from our clients, and probably one of the weakest aspects of the brokerage model, is where they don't get consistency of support worker. And we spend a lot of time working with our providers to get consistency of support worker and to allow that relationship to develop at the point of service. So there's a level of trust between the person and their family and the support worker. And I think if you're going to really transform this system, it's focusing at that point of relationship and investing in those workers and investing in the families to develop that relationship.
Yes, that looks like Ms. Brewer.
Yes, looking at it from the perspective of organisations that have a large voluntary workforce delivering services, Meals on Wheels SA has 7,000 volunteers around the state of South Australia, and 3/4 of them engage with us for less than 100 hours every year. Many of them are not digitally literate, and so our approach has tended to be through useful, succinct, written information, peer-to-peer induction and orientation to the service, and the support currently that we can afford with the level of funding that we have is for only less than 20 people and fewer full-time equivalents who are supporting the volunteers that are doing that peer-to-peer training model. So for future growth in that, additional appropriate funding that covers the cost of quality and safety and training of staff and volunteers will enable us to provide a richer level of training to the volunteers around person-centred care.
Yes, Mr. Vickard. That look off. No, you're on mute, I'm afraid. We can't. Yes, no, you should be okay now.
Thank you. From a Uniting Care perspective, Uniting Care, by virtue of its mission, is there to support and work closely with the most vulnerable Australians. In order to do that, what we have done over our histories is interrogate the evidence base, but also create the evidence base to actually support good person-directed care, as Mr. Corley put it, at the point of a relationship on the ground. So beyond organisations having sufficient safeguards and frameworks in place, it's how we actually have gone about introducing mandatory training, making sure that our staff are suitably skilled to deliver the care that's required, but to do that from a relational perspective. In terms of taking that forward, and what I do appreciate about the propositions from Senior Counsel are they are bold and they move to access and they talk to the need to respect everyone and be relational in nature and keep it personal as well, is that for the sector to move to that forum, there needs to be the capacity in there to look at things like self-reflection, resilience, what good person-directed care looks like, moving away from just the institutionalised settings that we are in, which is wedging people into certain service lines and looking at them holistically. So I think that's going to be a major challenge. And then also for the workforce of the future is how do they respond to services that people really need? As that evolution happens, and we've seen that with the NDIS, new service modes and types have evolved, which means that participants are in control and they actually inform the process. So there is a whole redesign of the service system, and I think the capacity of organisations to move into more customer-centred evolution of it will be the proof in terms of what the outcomes look like for a person and their family.
So if I might just try and draw that to a conclusion, I think what you're saying is the entire system needs to reform, and that a relational or system needs to be, or approaches need to be built into the formal training that's provided for the workforce, but also operationalised, provider by provider, and constantly focused, developed, evolved to take the system forward. So thank you. I really appreciate those inputs. That's all from me, Commissioner Pagoni.
Yes, thank you, Commissioner. Mr. Gray, you popped up again.
Yes, I repeat myself at a more appropriate juncture now. Could I ask that the panelists be excused, subject to any further questions that you might have?
No, thank you very much. I just wanted to join with Commissioner Briggs in thanking each of the panelists. It's very, very good to have your wealth of experience and knowledge in informing the approaches that have been recommended by Council assisting us and the group of people behind them who are helping in organising and moulding the proposed recommendations. It is important that they be tested with, as it were, people who are likely to run them and have got the experience and knowledge that each of you have. And we're very grateful that you've given the time and energy before today's session and that you've put up through this session the kind of information that you have. So thank you to each of you for doing that. I do now formally excuse you from further attendance. Thank you.
Could we resume?
Thank you, Commissioners. Thank you, Mr. Gray.
Thank you, Council.
Thank you. Could we resume at 2:10, Commissioner?
Yes, I think so. We'll resume at 2:10.
The Royal Commission is adjourned until 2:10 p.m. The Royal Commission is now resumed.
Mr. Gray.
Thank you, Commissioner. Just for continuity on the transcript, I'll mention that Mr. Ahlan St George has provided a response to the propositions we've been discussing in written form, and that has been included in the general tender bundle at tab 93. I believe there's an appearance to be announced.
Yes, who do we have?
Hi.
Elise Hilton, I appear for Higher Up Proprietary Limited.
Yes, thank you, Ms. Hilton. Yes, Mr. Gray.
Thank you, Commissioner. I call Jess Timmins of Higher Up.
Afternoon.
Ms. Timmins, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say I do.
I do.
Ms. Timmins, you represent Higher Up. What's your position in Higher Up?
I'm the head of service.
Thank you. And could you give an outline, please, of the origins of Higher Up and what Higher Up does, what its main operations are?
So Higher Up was founded by two siblings, Jordan and Laura O'Reilly. They had a younger brother with disability, and they saw that there was a better way that supports could be delivered. So Higher Up was founded, and we're an online platform that connects people with disability with support workers who fit their needs and share their interests.
Is Higher Up a registered NDIS provider?
Yes, we are.
And could you tell the commissioners about the different modes of management or support management of NDIS services that are available under the NDIS framework?
So there are three ways that a participant's funding and plan will be managed. There are self-managed individuals who have kind of complete control over how they use their funds. There are plan-managed participants who are supported by plan managers to expend their funds. And then there are agency-managed users who their funds are held with the agency.
And does agency in that context refer to a provider?
No, that refers to the National Disability Insurance Agency.
And what forms of services does Higher Up provide? Does it provide services to self-managed, plan-managed and agency-managed clients?
Yes, we do.
And does it provide plan management services itself?
No, we don't.
Okay. Now, what are the functions of the platform when it comes to workers who want to make themselves available over the platform? And what's the relationship between Higher Up and those workers?
Yeah, so all of our support workers are employed as casual employees of Higher Up. So they are able to create a profile on the Higher Up platform and then be reviewed before becoming an employee. And they can then interact with people with disability on the platform who are looking for support workers to provide support.
And what is the scope of the services provided by the casual employees who are made available for deployment on Higher Up?
So there's 8 different types of support on Higher Up, and they're all within the boundaries of the support worker job description. But the 8 different types of support include personal care, help around the house.
We'll go to the website, shall we?
Sure, yeah.
Operator, please bring up the website, the Higher Up website, the page How Higher Up Works. Thanks, Ms. Timmins. I interrupted you. You mentioned help around the house.
Yeah, so as you can see on the screen, personal care, in-home care, help around the house, transport, therapy support, out and about supports, specialist high needs support, and education and employment.
Just stopping at specialist high needs support, is that still a form of personal care, or is that some sort of therapeutic or clinical support?
It's typically personal care.
Right. And how does this part of the website work? This is directed at people who are seeking services, is it?
Yes.
But these categories are also relevant from the perspective of the person offering their services as a casual employee of Hire Up. Is that right?
That's right.
And if I want to become a casual employee of Hire Up, do I nominate which categories of services I'm prepared to offer? Is that how it works?
Yes, exactly.
And could you explain how Hire Up then ensures that those people are appropriate to be providing the relevant category of services?
So for the main categories of support, there are some really key verification steps that every individual employee goes through before they become approved to be an employee of Hire Up. But particularly for the specialist supports, we really work with the person with disability who's going to be receiving those supports to check that they have the appropriate allied health plans or clinical plans in place to support the support worker to do that work safely. And additionally,
Sorry, I'll come to that in a minute. But firstly, can I ask, what are the steps that Hire Up takes, if any, to ensure that a worker offering to perform services in a particular category is an appropriate person to be providing services in that category? Is there some form of checking of their qualifications or anything of that kind?
No, we don't check qualifications. We do collect those, and then the person with disability, if they have a requirement for a specific qualification for them individually, they can check those with the support worker.
Thank you. Understand. And how does Hire Up match a request for services by a person seeking services with an appropriate worker or appropriate list of workers who have nominated to provide services in the relevant category?
So I guess there are a couple of technologies that people can draw on. Firstly, they can search for support workers in their area and they can specify what types of support they're looking for. We also have a recommendations program that will show a person with disability some specific support workers that could be a good match for them. And then we also have a jobs board where a person with disability could post basically a job advertisement and have support workers apply to work with them.
Okay, thank you. Might just take those points and ask you a couple of further questions about them. If we could just ask the operator to click on, say, the specialist high needs icon. There are a number of detailed items within specialised complex support that appear on the website. That's probably a bit small for a lot of people to read on their screens, but they include manual handling, lifting, hoisting transfers, anaphylaxis, allergies, epilepsy, seizure management, etc., peg enteral feeding, I see. So we're getting into quite specialised services. Perhaps some of these would have to be performed under clinical, under a plan formulated by a clinically qualified person. Is that right?
That's correct.
But is it the case that the casual workers on Hire Up are not themselves taken to be clinically qualified? They don't need to be clinically qualified. You're in effect relying on some form of planning by a clinically qualified person being done outside Hire Up structure. Is that how it works?
That's correct, yes.
Okay, and how does, in practice, how does that come about? So you only provide NDIS services at Higher Up, is that right? You don't provide aged care services?
No, we don't.
So we're not talking about the aged care system per se, but in the NDIS context, how does that come about? Who provides that clinical planning, and is there any clinical oversight involved?
So perhaps a good example would be behaviour support and restrictive practice. So an individual who requires a positive behaviour support plan and perhaps restrictive practice strategies, they will be funded through the NDIS to have that work done by a behaviour support practitioner or a clinical psychologist. So they are able to work with a practitioner to develop the strategies and the plans that they want to use when they're receiving supports. And then they're able to provide that to Higher Up, for example, to review that plan prior to them receiving services. And then they're able to use that plan to train their support workers.
Okay, thank you. And just going back to the point about, from the worker's perspective, how do they nominate for, how do they offer themselves to be providing services as specialised as this? Is that simply a matter of their own discretion? Do they think, well, I think I could provide specialised supports in the nature of enteral feeding, I think I'll just nominate to be able to do that? Or is there anything more to it than that?
That they do nominate themselves to provide those supports, and of course they can then make a decision on an individual case-by-case basis as to whether they want to provide those services. So for example, if a person with disability was to reach out to them and ask them to provide say bowel care support, and they didn't feel comfortable or they didn't feel like they had the experience, they could decline to work with that individual.
Okay, and from the point of view of Higher Up's employment structure, including any quality assurance or training program, does Higher Up have any sort of process of supporting employees who are taking on these quite complex tasks, or is it simply a matter of the discretion of the employee and it's left at that?
So we do have a team that supports both people with disability and support workers who are delivering more complex supports. And so that will, from the support worker side, that can be about checking that they feel comfortable, checking that they have access to all of the information they need, so the plan, for example, and checking that they are feeling ready and confident to provide those supports.
All right. Now, from the perspective of the user of Higher Up, what functionality is Higher Up offering to them which can in effect empower them when it comes to autonomy in arranging their own supports, the times at which those supports will be given, the people who will give them?
So yeah, we've harnessed technology to really allow a person with disability to build strong, reliable, consistent relationships with the support workers that work on our platform. They're then able to use different functionality, such as our booking management system, to say to a support worker, I would like you to work every Monday from 9 till 12, to book that into that system, and then allow that support worker to be paid for that work as they complete it.
So looking at the website again, if I need catheter care and I click on that and I go through a process of saying where I live, do I get to a point where I can nominate times I'd like those supports to be provided? And then that generates a list of people and I can look at their profiles. Is that how it works?
Not exactly in that order, but yes, certainly the key elements are there. A person with disability will create their profile. They'll nominate the types of support they're looking to receive on Higher Up. They'll then use our technology to find support workers that could be a good match for them, and then they will book them and roster them in.
Returning to the, in effect, the internal arrangements within Higher Up, and in particular that casual employment model, why did Higher Up decide to adopt an employment model first up, and why a casual employment model secondly?
So I think the decision to be an employment model was a really profound one for Higher Up, and has really driven our culture and the way we think about supports. I think our founders believe that the duty of care that's created when you are an employment model can lead to higher quality support outcomes for people with disability. And so we really wanted support workers to feel part of our team and committed to those same quality outcomes.
And why casual employment?
Yeah, sorry. I think casual employment obviously allows support workers and people with disability to have the flexibility to work when suits them. So that was the best option for us to start with.
And is there an award that applies to the conditions of employment for the casual employees on Higher Up?
There is, yes.
And does Higher Up have any plans to offer different employment models?
Yes, we do.
And what's that? And what are you doing to investigate that?
So I think we believe that the future of work is about having a spectrum of employment options available. So the next step on that evolution for us is the trialling of a permanent employment model for disability support workers. And we've designed that model around the relationships that people with disability and support workers have through Higher Up.
When I asked you the question about why had Higher Up chosen an employment model, you referred to a belief about a better quality and safety outcomes, or better quality outcomes, and you referred to supports of employees, support that can be given to the workforce. When you say support to the workforce, what exactly do you have in mind? When I asked you the questions about the categories of support that are provided, it seemed that in large measure, it's up to the employee to nominate which categories of support they want to provide, including quite technical ones. So what is it exactly that Higher Up does to support its workforce to be able to provide the sorts of supports that Higher Up is offering on the platform?
So I think a really key support is obviously the investment in learning and development for support workers. So by providing support workers with access to different training, they can build their skill set and experience to be able to provide more complex supports, as an example.
And does it stop at learning and development, or is there other support that's provided?
No, there is other support. So, for example, we can conduct check-ins with our support workers. Through COVID, we've started running online sessions to listen to the challenges that support workers are facing at this point in time, to be able to respond to those challenges and provide them with key information about how they can work safely through COVID, as well as, for example, in the bushfire crisis, we're able to offer different financial support to our support workers who are volunteering as firefighters. So I think what it creates is a mindset around support that enables us to respond to the context that that support worker is in.
Is the training or the learning and development tailored to the nominated areas of work that the worker has included in their profile on Higher Up?
Yes, we are tailoring.
And in addition to check-ins and learning and development, is there any other support that you see as an advantage of the direct employment model of engagement of a care workforce?
I think a great example would be the support that's offered to support workers who injure themselves, whether physically or psychologically, through through their work on Higher Up. So we have a dedicated injury management team that supports any injured worker to make a claim for workers' compensation, to receive alternative duties to complete whilst they're unable to provide support work, and to eventually return back to work. And I think that's a really important difference for our support workers.
Can I just ask you a bit about the internal structure of Higher Up? Not in great detail, but is it the case that you're running a large team called the service team, but within that there are various other teams? Is that right?
That's correct, yes. Yeah.
And one of them, in fact, relates to injuries by employees, does it? Is that how it works?
Yeah, so we have a trust and safety team. Within that, there are people specialising on injured workers and their return to work. There are people specialising on incident response and complaints handling.
Now, I want to ask you about what happens. We're back. I think the website might still be up. We can take it off in a minute. But this area that we were looking at was the complex, or specialised brackets complex supports, wasn't it? And
That's correct.
Is there a team within services that is responsible for clients who have specialised needs of that kind?
There is, yes. We have a complex support team.
And about how many, in rough percentage terms, are we? How many clients using Higher Up have needs of that kind?
It would be about 20%.
Okay, and what are the functions of that group when it comes to the supports that are needed for the individual clients and for supervision or direction of the workforce of personal carers who are looking after them?
So there's a strong focus on helping a person with disability to join the platform and to make sure that we have all of the information that we need in order to deliver support safely. So again, to take a behaviour support example, that might be the provision of their behaviour support plan for review by our complex support team. That also is around ensuring that the person with disability understands how to select their team, how to make sure that their team are trained in the safe use of that plan, how to draw in allied health professionals to support that training and that guidance. And then for a support worker, it is also about making sure that they understand what's required of them to provide that type of support, that they understand what reporting obligations that they might have, and that they know that they can raise concerns or ask questions of the complex support team if they have them along the way.
Thank you. Now, I should have asked you to describe what else is done within the service team. Is it correct that there's an onboarding team as well?
That's correct, yes.
So can you just answer, without going into all of the details, can you just answer this? It's not, is it the case it's not simply a matter of a client choosing on the website the domain of complex or specialised support? There's actually a process by which a team within Higher Up looks at the support plan that's been generated for the client and makes some sort of decision about whether complex support is going to be needed. Is that right?
Yeah, so there are a range of different inputs, I guess, into helping us understand what types of support that individual is looking for and whether we need to provide more tailored onboarding experience. So that includes the profile that they've created, some answers to some key questions about what types of support they're looking for, as well as other things like phone and email conversations to really understand more.
And is there an analysis of whether the person is going to fall within that roughly 20% portion of your clients who are going to need that more tailored management of their needs. Is that right?
That's correct, yes. And then that's transferred to the complex support team.
Now, with the complex support team, sorry, I'll withdraw that. I'll start again. Generally speaking, do you regard the clients on your platform, perhaps the 80% of clients who aren't clients with complex support needs, as self-managing their support plan?
Yeah, so they're definitely self-managing their supports within the context of HireUp. They might be using any of those three funding mechanisms that the NDIA provides.
Yes, thank you. Now, when it comes to the 20% or so of clients who are in that domain of complex needs, are they self-managing?
Some of them may be, yes. Well, they're self-managing in the context of HireUp. That's consistent no matter the type of support you're receiving. But again, they might have varying forms of funding arrangements with the NDIS.
And what then is the role of the complex support team? Is it just to keep an eye on the way in which a person in that group is self-managing?
Yeah, so I think it's important to call out that we have people with disability on HireUp can nominate an account manager that can support them to use HireUp and to train support workers. So for someone with more complex supports, they might nominate an account manager to support them, in which case our complex support team would be working with both the account manager and the person with disability to make sure that everything's working in the way it's expected to.
Typically, who is an account manager likely to be? Could that be a family member?
Yeah, it's typically a family member, an unpaid person in that individual's life.
All right. And can you tell the commissioners about the safeguarding measures? I believe they're called safeguarding measures that are taken by HireUp within the context of the NDIS. What are safeguarding measures?
So, yeah, we made the decision to be an NDIS registered provider, and that decision, I guess, bolsters our existing commitment to quality and safety, but also provides a framework for the safeguards that we need to put in place. I guess the key safeguards that we have in place are mandatory training for support workers in certain topics. We also have a post-booking feedback form that allows support workers to provide information about what happened on the shift, to report any incidents, to raise any concerns. And then we have a 24/7 incident form that's monitored by a team around the clock.
Are there additional safeguards for people with specialised needs who are within that 20% cohort?
Yeah, so there are typically, a higher standard of reporting is required. So again, to draw on the example of behaviour support, support workers who are providing support to an individual with those requirements are required to report the use of restrictive practices, whether authorised or unauthorised, through our platform.
Okay. Now, what's the effect of being registered as an NDIS provider on HireUp's decision to take those steps? Are you taking those steps because you're a registered provider, or are you taking those steps irrespective of registration?
I think we'd be taking those steps irrespective of registration. As I said, we've always felt that there was a role that HireUp should play in ensuring high quality and safe supports are delivered. But I think what the regulatory framework provides is guidance and direction on how what standards should be met, and that forces us to think, innovatively across every step of the journey for the person with disability about how we provide quality and safe outcomes. And it also requires you to really analyse your performance against those standards and against those quality outcomes. And I think that leads to continuous improvement.
So has it made a difference in your opinion? Firstly, when did HireUp become a registered provider under NDIS?
So
From the outset
we
or
first,
recently?
sorry, we became registered in New South Wales in 2016. So prior to the establishment of the Quality and Safeguards Commission in the NDIS, it was a state-by-state registration process. So we became registered first in New South Wales in 2016, then in the ACT in 2017, and then in all other states and territories in 2018. With the exception of Western Australia, who we're still in the process of applying to become registered.
All right, thank you. And has it made a difference? Are you able to give an opinion as to whether being registered, because of that guidance that's provided by the regulatory framework, whether that's actually made a difference to the rigour of the safeguarding practices within HireUp?
Yeah, it absolutely has. It's provided a framework for all of us at HireUp to think about quality and safety in the same way, in a consistent way, and to make it all of our jobs to make sure that we're designing and building for quality and safe outcomes in everything we do.
Right. Now, we gave you a copy of some draft propositions that have been considered by the Royal Commissioners in the light of the evidence in this hearing, and we didn't ask you to provide a written response, but you indicated that there were some propositions to which you were prepared to make responses, as I understand things. One of those was 6B, I believe. That's a proposition that it's in the aged care context, of course, and you don't operate in the aged care context, but it's a proposition that engagement of contract and sole trader aged care workers, including through online worker brokerage platforms and labour hire arrangements, be regulated. And firstly, would that be practicable in a disability context? I guess it must be if you are regulated through having taken registered status as an NDIS provider. Do you have any response to that proposition? Do you believe that would be appropriate in a disability context for all similar businesses, similar to HireUp?
Yeah, I think that in the context of the disability sector, and particularly the NDIS, the ability for a participant to choose between a registered and unregistered provider is a really important concept, and I think we would want to see that maintained. But yes, speaking from our experience as a regulated employment model, as we've talked through, we've really seen the benefits of that regulation in providing guidance and direction and a mindset and culture around quality and safety, and we would see that others could benefit from that too.
All right. Now, it's interesting, just in the course of your answer, you said that it would be useful to preserve that choice, or appropriate to preserve the ability of the provider to choose. And why do you say that? Wouldn't that mean that you've got to compete with unregulated platforms who may be not adhering to labour conditions and may be able to compete against you on price potentially at the risk of quality compromises?
Sorry, what was the question?
So the question is, why do you say it's important that online platforms who provide workers in the care context or disability support context be allowed to choose whether to become regulated or not? Why do you say that?
I think the choice I was referring to was for the participant, so the person with disability, for them to be able to choose between a range of different service providers that meet their needs. So for some individuals, they are looking for supports that that perhaps don't require as much regulation, and there should be great options for them to choose from within that. But there are other supports that could benefit from regulation. So I think really the choice we're referring to there is for the participant, the person with disability, as opposed to the provider.
Thank you, I understand. And how would you discriminate between the services for which regulation is appropriate and the services for which you needn't have regulation, and in fact it would be useful to accord choice to the consumer to choose providers who aren't regulated? How would you make that judgment? Is it something to do with the inherent risk of the service?
Yeah, I think so. I think it's about whether there can be that fine balance between the dignity of risk for a participant and the duty of care for quality and safe outcomes. So, that choice should be an informed choice by the person with disability. They should know what they are, what types of support they're receiving. But I think, it really depends on the risk profile and what that each unique individual is looking to receive.
Does it also depend on the capacities of the person seeking the supports? And again, we might be dealing with a very different context here because disability is quite different from aged care. But are you able to answer that question? Does the answer to the question whether to regulate or not also depend on the riskiness of providing services to a particular individual, and in particular, does it depend on their capacity?
Yeah, I think that to speak from our experience, we've always believed that to be a self-manager of your supports on Hire Up, there is a requirement for the desire and capacity to self-manage to be present, and that Hire Up and models like it aren't going to be for every single person with disability who are utilising NDIS plans. So again, that's why there should be choice of different providers available depending on that person's desire and capacity to manage their supports in the way they wish.
Does Hire Up do anything to try to understand the capacity of the clients who are putting a profile on Hire Up and trying to use Hire Up to obtain services from your employees?
Yeah, so we have an onboarding process that reviews each application that's coming in, and we draw information out of that. We may have phone conversations or email conversations to just check and see whether that person might have a better experience using Hire Up if they were to have an account manager in place, for example.
And are there cases where Hire Up has declined to accept a person using the platform to obtain services, even with an account manager?
Yes, there are.
And how's that judgment made?
Yeah, so it's a mixture of looking at the types of support that the individual is wanting to receive, the social structures and networks that they have in place to make sure that those supports are delivered well and safely. And then it is a judgment by our onboarding team as to whether Hire Up is right for that person right now or ever.
All right. Now, how have you calibrated, how have you worked out the degree to which Hire Up should, in effect, intervene in the process of the client being able to just exercise autonomy in using services on Hire Up in situations of the kind you've just referred to? How do you know that you've got it right?
I think, it's a question that we're always actively considering, and we draw on a range of different inputs. We look at the risks, the risk profile that's emerging. We look at incident reporting and other feedback loops to determine, are we getting it right? Should we be intervening? I think what we would say is that what we're hearing from our community is not that they want more intervention into their supports. They probably would like to see them be able to be more in control of their own safeguards and their own quality framework. So we keep listening to the community on that one, and if we see that need changes, we'll respond to that.
One of the propositions to which I understand you expressed some willingness to respond was proposition HC3. Again, this is an aged care context, and there are different considerations in play, I suggest. For example, the possibility that the person needing the services might be quite old and might be facing quite a dynamic situation when it comes to deterioration of function. Now, putting that to one side, do you find it possible to answer this question? In proposition 3, we proposed a shift from self-management to shared management, where the focus will be around delivering care to meet assessed needs. And earlier we've talked about, and this is consistent with the legislative regime, working in partnership, the provider working in partnership with the older person to make decisions in that regard. Would that be workable in a disability context? Do you have any reaction to that proposal, or you? I'll let you answer. Would that be workable in a disability context, or does that infringe your model?
I think it's really important in the disability context, particularly within the concept of the NDIS, that commitment to self-management is maintained. But that's not to say that approaches that take more of a shared management approach can't be successful within the context of the NDIS and disability. But I think because the NDIS has been built on human rights principles and self-determination and self-management are core to that, we would really want to see that maintained.
No further questions, Commissioners.
Yes, thank you, Mr. Gray. Commissioner Briggs?
No, I don't think you.
Yes. Ms. Timmins, thank you very much. It was very interesting perspective that you bring to our inquiries. It was very interesting to see how your activities in a different but allied related context might provide valuable insights into how we might come out with our recommendations. So thank you very much for the efforts that you've put in both before today and today. Thank you very much.
Thank you very much.
Great.
Thank you. So if Ms. Timmins is now excused.
Oh, yes, I keep forgetting. Yes, Ms. Timmins, you're formally excused from further attendance.
Thank you. I'll now call Mr. Peter Scutt of Mabel.
Mr. Scutt, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say I do.
I think Mrs. Scutt may be on mute.
I do.
Thank you.
Mr. Scutt, are you the founder and chief executive officer of Mabel Technologies Proprietary Limited?
I am.
Mabel has provided a number of documents in the nature of submissions, and I'll just refer to where they are in a tender bundle that the commissioners already have. There are submissions from Mabel at tabs 17, 18 and 19 on various topics relevant to the Royal Commission's inquiry. There is a specific document in the nature of a submission responding to the propositions for this hearing at tab 47, and there is also a supplementary submission at tab 84 relating to the functionality of Mabel with respect to care management. That's all correct, isn't it, Mr. Scutt?
It is.
In that last document at tab 84, it's a brief document. It's a factual account of the functionality of the Mabel Care Manager Coordinator feature.
That's correct.
Are the contents of that supplementary submission true and correct?
They are.
Thank you. Now, if we just start with that document, I'll ask the operator to bring up tab 84 of the tender bundle. There's been a good deal said already today, Mr. Scutt. I don't know if you've been following the hearing so far, but there's been a good deal said by me and asked by me about care management, sometimes called care coordination. And I'm just going to ask you a couple of questions about this document and about the care management functionality of Mabel. Just for a bit of background, it emerges from the other material you've furnished to the Royal Commission that Mabel is a platform that facilitates engagement between care workers who have put a profile on Mabel and third parties who want to engage those workers. Is that a fair summary?
That's a fair summary.
And those third parties might be the people who are wanting to receive the care themselves, or they might be other care provision organisations. Is that fair?
Well, the predominant focus of Mabel is connecting people with people. So the predominant person that wants to connect with workers are the individuals themselves, supported by families or a care manager. More recently, we've opened up the platform more fully to providers that might have needed Mabel during the current challenges.
Thank you. So that's that use by Mabel to engage workers by organisations is the exception, not the rule. And the model is all about direct connections between people I might call care recipients and workers. Is that right?
That's right. And we think connecting people directly is a key proposition of Mabel.
Thank you. Now, you also mentioned care managers just in the course of that explanation, and that there might be a connection with a care manager. And this, can I just clarify a particular scenario, see if you agree with it? If we're talking about people who are holders of a home care package subsidised by the Commonwealth, then that person will have a home care provider who in effect hosts the package and administers the funds from the package. Is that right?
That's correct.
And in some cases, there'll also be somebody variously called a care manager or a care coordinator, and there might be other titles, whose role might be to ensure that the individual is getting care that has been planned for that individual. Is that a fair summary?
Well, I would say in the case of a home care package recipient, the home care provider is not only responsible for the administration of the funding, they're responsible for the care management. So there'll always be a care manager working with the client and around individualised care plans and making sure that they're able to access the services they need in relation to the care plan.
So you've corrected my summary to the extent of saying, well, there should always be a care manager. If the person has a home care package, there should always be a care manager.
100%.
But otherwise, was my description accurate?
That's right. And that there would be potentially a care manager supporting the client to use the platform, or there would be a care manager supporting the client. And in the case of a home care package, it's the same organisation that's essentially managing the package.
Okay, thank you. And when you say managing the package, you're talking about the funds management, that is.
That's right.
Issuing invoices, I beg your pardon, paying invoices.
The package.
And thank you. And presumably also giving a monthly statement to the client of amounts spent out of the package and how much is left in the package and things of that nature.
That's correct. All of the responsibilities under package management and care management would remain if they have a client using the Mabel platform.
Now, with Mabel, a care recipient is able to nominate the kinds of care they need, the area they live in, and to generate, in effect, a list of people who are offering services via Mable that meet the description or match the description that the care recipient has put into the Mable platform. Is that correct?
There's a range of filters that people using the platform can use either when posting a job or when searching for care workers to start to shortlist a group of people who could be suitable for the needs based on the criteria they're articulating through those filters.
And you've explained in your material, but that the tailoring or the filtering can be quite detailed, extending to things such as common interests, certainly linguistic abilities, in particular languages, not simply what geographic area they're in and what times they're available to work. Is that a correct summary?
That's correct. Our experience is that the people who are invited into somebody's home and life to support them, it's a very intimate and personal decision. And so it does get down to very much cultural preferences, languages spoken, interests, and people want to form a connection with the people that are supporting them. So that's the foundation of a good relationship.
Yep. Now, in the supplementary submission at tab 84 on the Care Manager Coordinator feature, one of the things you've said is that a home care package client cannot use the Mable platform without the approval of the client's home care package provider. Is that right? There's some sort of block, is there, which would prevent just an individual member of the public using Mable if they tick a box to the effect that they're a home care package holder?
So somebody that's not a home care package holder can use the platform if they're privately funded. But when it comes to the process of a consumer signing up to the website and providing information, one of the things we look for is their source of funding. So if it's if home care package is their source of funding, then we would require, our process is to actually understand who their home care package provider is, and we would contact that home care package provider to verify that their client is able to use Mable to assemble a tailored team of support. So without that verification, the client is not able to spend home care package funds on the Mable platform.
Thank you. And as you've said, you expect that in every case of a home care package holder, there will be a care manager appointed by the home care provider hosting that package, correct?
Correct, because it's their responsibility to do care planning with the client and provide care management as part of the home care package.
And you've said in the document that the way you've constructed Mable allows the provider to create logins for its care managers so that they can see the activity on the Mable account. Is that right?
That's right. We've set up the structure where there can be an organisational login. They can set up logins for all of their care managers, and the care managers can be linked to their clients using the platform.
And on the last page, page 3, we just ask the operator to go to page 3. Under functionality, there's a list of functions. The Care Manager platform feature enables each care manager to, and then there's a number of things that can be done. Is that an exhaustive list of what the Mable platform as a whole enables each care manager to do?
Yeah, so I think it's a fairly comprehensive list. I think the two aspects of a client using Mable for a home care provider is the care manager continues to obviously have an ongoing relationship and dialogue with their clients that are using the platform. They can have an ongoing dialogue with the workers that the client engages. And then via the login, they have a lot of oversight capability as listed here.
All right. Well, I'm interested in that idea of the provider having an ongoing dialogue with the worker who's appointed. It doesn't appear from this list that there's any functionality on the Mable platform by which the care manager can interact with the worker directly. Is that right?
So I think if you look at some of the functionality here, they're aware of which workers are being engaged by their client, by the platform. They can look at their profiles. They can look at their respective documents. They also can see.
I understand that, Mr. Scutt, but can you just answer my question first?
Yeah.
And then I'll let you explain those points, because it may be that there are indirect ways in which the provider can interact with the worker. But am I correct in saying the Mabel platform itself doesn't provide a means of direct interaction with a worker appointed by the provider's client? Is that right?
That's more or less correct, other than the case manager can essentially log in as the client and see all of the discussions that are happening between the client and potentially also send a message. But most of that interaction happens off the platform.
Okay. So you're saying that the case manager can assume the identity on the computer of the client and send a message?
They can, if necessary, log in as the client to support the client using the platform. So whether it's to log in to help the client formulate a message to a worker or post a job or approve a service log, they can take those actions on behalf of clients that are linked to them.
Okay, that's useful to know. Nevertheless, it's not a design feature. That's a bit of an exception, a bit of a workaround, is it?
No, I think it's the recognition that when using the Mabel platform, the consumer can operate the Mabel platform on their own with oversight by the care manager, or the care manager can support the client using the Mabel platform in more or less a supported decision-making process where, if necessary, they can help review some of the profiles on the platform. They can help formulate the messages by logging in as the client and supporting them to use the platform. Now, so it's actually a contemplated design feature that the care manager can actually support their client using the platform.
What's your opinion of, firstly, the legal relationship between Mabel and the workers who put their profiles on Mabel, in effect offering themselves for engagement as care workers? What's that legal relationship? Is that an employment relationship? What is it?
No, I think that the care workers that want to offer their service via the platform, they sign up as members of the platform and they accept the terms of use, including abiding by codes of conduct. So essentially, they're customers of the platform. They're not our employees. We're not contracting with them other than as a client or customer of the platform.
And what about the relationship between the home care provider who's hosting the package and providing those administrative functions, funds administration, and also care management? What's the relationship between the worker and the provider, in your opinion?
Okay, so I think it's in our model, it's the client engaging directly with workers on the platform, and the care manager or the approved provider is required to make sure they comply with the Aged Care Act, with the quality standards and their functions that are required. And I think the relationship is one where essentially I would say, best they may be considered to be subcontracting those services, but I think it's really the client engaging those services directly.
All right, so let's just take that a step at a time. You started by saying the client's directly retaining the worker, and you finished by saying that. In the middle, there was a reference to, at best, it could be subcontracting, but we might come back to that. One of the things you also said was that the provider is required to ensure that they, I take it you mean the worker, complies with the relevant standards, which are standards scheduled to the quality of care principles. Is that what you have in mind?
No, I think what I was referring to there is that the approved provider themselves is responsible for complying with those quality standards.
Yes, all right. So the approved provider is required to ensure that those standards are met even by the work provided by a worker directly engaged by the client. Is that your position?
That's. Could you, sorry, just repeat that question for me?
Yeah, it's difficult. It comes out of what you said about
Yep.
the approved provider being required to comply with the standards. And it's a conundrum in my submission that's raised by your model. You've said the provider is required to ensure that the standards are met by the care that's provided, but you've also said that the provider is probably not engaging the worker, the client is engaging the worker. My question, firstly, have I got that summary of your opinion correct?
That's right.
Okay, next question. In the absence of a legal relationship between the provider and the worker who's been obtained and engaged by the client, not by the provider, how is it, you say, that the provider would be able to ensure that the standards are met by the care provided by that worker? They're not under any sort of obligation to comply with directions of the provider, are they?
So how I would answer that is that the provider can rely on the operations of the platform for part of the answer to responding to complying with the quality standards. So, for example, in an agreement with a home care provider, we give some undertakings in terms of how the screening process works on the platform. So they can be confident and have undertakings that all workers on the platform have a police check that's not more than 3 years old, that we've applied a police check policy in assessing that police check, that they've undertaken reference checks, that they have certain qualification checks for the services they offer, which I can talk to in detail, that they have insurances in place. So there's a number of features of the platform that give the provider comfort that those features are aligned with many of the requirements under the quality standards. But in addition to that, the provider is able to, through the oversight functionality here, understand the services that have been engaged by the client, the qualifications of those workers. They can see the shift notes, they can see incident reporting, they can see the qualifications of those workers, and they have a direct dialogue with their client in terms of, are they getting the outcomes that are seeking? They can also ask workers on the platform to provide more information. So between the safeguards that are built into the operations of the platform, which they have comfort around and commitments from us to operate the platform in those ways, they also are able to stay in contact with their client and have oversight of the client's activities on the platform. And I think that gives them enough understanding, in addition to their own capabilities, to be able to comply with the quality standards.
All right, so I think what was missing in all of that, I mean, I'm not seeking to diminish the weight of those incidental measures and the screening and the visibility through the Care Manager platform functionality that you described. Those are no doubt important, but there isn't an ability to direct the worker, is there?
No, the provider doesn't direct the worker. We don't direct the worker. The workers are independent contractors, in most cases providing services directly to their clients.
Yeah. So you're making available this level of visibility to care managers of providers, but there's no compulsion on you to do that, I suggest, is there? You're not regulated in any way to require that level of visibility?
So we're not directly regulated to provide that level of visibility, but there's a couple of motivators for us doing that. One is we believe very much in the value of care management to people that want to self-direct or self-manage their funding. We're very big advocates of care managers being independent of service provision, so they stand beside the client. So we want to basically be able to allow care managers to support their clients using the platform and effectively engaging a team of their own. The second motivation is that there are many home care package clients that want to take this level of control. It's really important to them who they engage to provide these services. And because the provider is a regulated entity, we do whatever we can to help that provider meet their regulatory obligations. So there's certain things they can rely on us for around police checks and the operations of the platform, but we also want to give them this level of visibility, one, to improve the outcomes, and two, to allow them to be able to meet their obligations.
So what's, in your opinion, the legal relationship between Mabel and those providers who are hosting home care packages and providing care when they should be providing care management. What's that legal relationship? Is it subcontracting? What is it?
Oh, it's the approved provider has a login to the platform. They become a member of the platform. They sign up to the terms of use, and so they're a customer of the platform.
You've got a criticism of our proposition HC3 for shared management. You say, and when I say you, I'm referring to Mabel's submissions. This in particular is GTB 47 at page 9. Operator, we can take tab 84 off the screen now, thanks. You say shared management should only be offered as a choice. It shouldn't be a default form of management. And you refer to the existing regime under the user rights principles, which in effect require a partnership approach to budgeting for care and itemising a budget for care in the home care context. And you've said, if we put up tab 17, please, operator, at page 9, you've said that our proposition about shared care management implies that providers will have power over what services will be delivered to meet assessed needs rather than recognition that consumers have the capacity to make these decisions. Mr. Scutt, if we put up tab 17 at page 9 at the foot of the page, that's an earlier submission where you were GTB, I beg your pardon, operator, GTB 17 at page 0002. Page 0002. That's, yes, thank you. And at the foot of the page, you refer to look, I'll withdraw that. We can take that off the screen. Thanks, operator. Your concern about shared management, have I summarised it correctly, that you believe that shared management should only be offered as a choice? It shouldn't be a default requirement?
So I think the context of my answer there was to say that I think it was also in a following part of your proposition is that we're moving away from self-management, and I think self-management is a critically important option for consumers, particularly with, you know, a desire to build capacity and for consumers to be informed and have access to care management. And I guess the question about shared management is really what defines shared management. And the fear that there is generally a bit of an imbalance in power and information that exists between consumers and providers, and a fear that sort of shared management, if self-management is withdrawn as an option, really continues to have the provider having an undue amount of influence over the provision or the choice of services for consumers.
In one of your earlier submissions, this is tab 17 at page 0022, you referred to, I'll just let the operator bring that up, but I'll just paraphrase it in the meantime. You referred to consumer-directed care, and you said in the context of consumer-directed care, duty of care should be more clearly defined as supporting a person to achieve their chosen outcome. This is near the foot of 0022, operator. As supporting a person to achieve their chosen outcome, as long as they are acting reasonably, considering both the risk and rewards, and where necessary, explaining the risks and possible ways to mitigate the risk, which may include building the consumers natural safeguards available in their community. Operator, is that?
Seems to be a wrong page.
Yeah. It's 0022. The foot of page 0022. Not 0002, but 0022. Thank you. I'll just let you at the foot of the box section is the passage I just read out. Mr. Scott, if you could just have a look at that. In the context of CDC, duty of care should be more clearly defined as supporting a person to achieve their chosen outcome as long as they are acting reasonably, etc. Isn't that really a description of a shared management model?
Quite possibly. I guess the earlier comment was not understanding what was meant by a shared management model. It wasn't necessarily defined or made clear, and I guess there's concern about the undue influence providers might have in the imbalance of power in that relationship. I guess what I'm talking about here in this submission is really the whole challenge that the sector has around balancing duty of care with dignity of risk, and the desire for, and it's in in CDC legislation around the desire for people to be able to make choices about their life that will involve a level of risk, the dignity of risk, balanced against the duty of care providers have to keep clients safe. And so there's an unresolved conundrum or tension in those two things, and it was an attempt to try and work out how to resolve those things.
All right. If we go now, operator, please, to tab 37. This is a statement of Dr. Paula McDonald. And Dr. McDonald has conducted a deal of research into digital platforms in particular and other forms of brokering of labour, including in the care context. If we go to page 002, she says, she identifies a number of criticisms, Mr. Scott, of those models. She says there are critics who argue that the organisation of platform work fragments work, de-skills professionals, places pressure on pay rates and reduces employment security. Now, just to take each of those in turn, referring to the fragmentation of work, Dr. McDonald is referring there to the fact that the arrangements for work might be spread throughout the day and the week at odd times, and there isn't continuity of work time, making it very difficult for some people to organise their lives. Is that a fair criticism in your opinion?
No, I don't think it is. I think from a number of perspectives, Mabel as a platform isn't an on-demand or gig platform. It's a platform that connects people and allows them to form ongoing relationships. So it's not piecemeal work. I'd say the other challenge is in home care is the fact that you have people with individual needs, preferences, abilities and interests that are all geographically spread. They live in homes and communities all over the country and are being provided services through approved providers. And in trying to meet the needs and preferences of those individuals, the existing sector today exhibits these characteristics. So a lot of the workers would complain that they have uncertain rosters, they're not paid for travel time, they might start at the beginning of the day and have gaps and then have further work at the end of the day, because typically the clients that are engaging them are restricted to the people they work for. One of the things I think with Mabel, when you actually bring large numbers of people together in local communities around a relationship model, you're actually able to get workers, work schedules that are more flexible and fitting in with their requirements. They're agreeing those schedules directly with their clients. And in fact, when you put two people together, they actually are much more flexible together in working out what works for both parties.
One of the one of the benefits that you highlight in your submissions of the Mabel platform is it makes the care package dollar go further.
That's great.
And you point to, in effect, lower rates, lower unit rates for the provision of personal care services over Mabel compared with other models such as direct employment models. Is that right?
Well, I actually point to two drivers of that. One is that the current charges for package management and care management can be fairly significant. In many cases, that can be up to 35% of the package. So that leaves 65% of the package to spend on services, and you may be engaging those services at sort of $55, $60 an hour. Part of the challenge for providers is there's a lot of work in that rostering equation to try and make sure changes to rosters have implications for the rest of the workforce and the rest of the clients. So when you shift some of the ability for consumers to work out the rosters and make choices directly with workers, you reduce some of those charges. So you can reduce the administration and care management fee maybe from 35%, it might be to 15 to 20% or 25%. So there's more money for services, and then you're able to engage those services directly from a team of your choosing, and it might be at $40 an hour versus, say, a provider charging 55 or 60. Those two factors mean you can potentially get almost double the hours of care support in some cases from the same funding. And I think, as you pointed out earlier, there's a direct relationship between the amount of support you receive, reducing the risk of somebody going into, say, residential aged care or needing more expensive services. So we certainly think those extra hours are a big driver of quality of life, of having more relationships in your life, and being able to do things beyond just the basics of, receiving domestic assistance or your clinical support, but you actually can use that support to remain engaged with your community and maintain relationships.
Is the other side of that an erosion of pay rates and job security?
Not at all. I think the exact opposite is the case. So independent workers on our platform offering social support and personal care, Monday to Friday, they're now earning on average over $36 an hour. And so the worker can be better off and have choice and control and flexibility and feel empowered in managing their own work arrangements. And the client can be better off in terms of a lower fee and more hours of work. And in fact, more hours of support. And more hours of support translates to more hours of work available for that support team. So again, if you're doubling the hours of care and support from the same funding, that's doubling the amount of work available in local communities around Australia at higher average rates.
You mentioned one of the implications of the use of Mabel is lower amounts spent on care management. Can I just ask you about that and what that implies? Is this essentially a product or a platform that's tailored to some people who are on home care packages, but is not appropriate for people with complex and intense needs who require a good deal of care management?
Yeah, so there's two parts to that question. I think the first one is a lower cost for package administration and potentially the care coordination piece of care management. So you're no longer having to manage that roster, which is quite a time-consuming and expensive piece of the operation of a provider when they're trying to roster services to clients that are geographically dispersed with individual preferences. But as far as care management goes, people need different levels of care management depending on their circumstances and the complexity of needs. So in our view, and I think this is part of your proposition, which I applaud you for, is that care management should be separately funded according to need. So some people will require initially low amounts of care management. They may be just requiring a little bit of support to, support their independent living. People may end up with quite complex clinical needs with fewer family members around them and requiring a lot of care management, and it may vary over time. So I think care management is something that should be independent of whether they use the platform or engage their services in other ways. But I do think there is a lower cost of care coordination that is also charged for through the care management fee.
Just back on the labour conditions, you mentioned $36 an hour for personal care. didn't Mabel, at the time of engaging with the Victorian on-demand workforce inquiry, inform that inquiry that the lowest wage payable for work mediated through Mabel's platform was $23.50 per hour?
Yeah, so when we provided that information, we have a protection for workers that they can't be engaged at a rate that would cause them to earn below minimum wage after accounting for super and platform fees. It's now $25 an hour, not $23.50 an hour, so that's gone up. But also at the time we made submissions there, the average rate of earnings of personal care workers and social support workers on the platform was between $32 and $33 an hour. So one thing we're seeing consistently is average rates rising about 8% per annum. And that points to the fact that, it's not a race to the bottom that people typically criticise platforms for. In fact, consumers really value the people that support them and want them to be fairly rewarded and feel valued. It's absolutely no evidence on the platform of any form of race to the bottom. In fact, the data suggests the opposite.
Again, Mr. Scutt, assuming that what you've done with respect to visibility for care managers and what you've done there by building in a floor for the rates that can be negotiated over Mabel based on at least the minimum wage, assuming those are good things, there's still no compulsion on an online platform to do those things. You're effectively doing them because you're persuaded that it's good practice to do them, but you're not being compelled by regulation to do them. Is that right?
No, that's correct. And I think, one of our company values is do the right thing always. I think the team believe in that 100%. But I think it's also the right thing to be doing for a business. We think of our business as a for-profit, for-purpose business, that unless we actually deliver on the purpose, we don't have a sustainable business. And so having sensible safeguards in place that protect both customers of the platform, the workers and the consumers, I think is just, you don't have a long-term future if you're not thinking about that.
Now, you've responded to a proposition that we've put regarding workers engaged through online platforms need to be regulated, or the mode of engagement of those workers needs to be regulated. You've given qualified support to that in your response to our propositions. You said the regulation needs to be proportionate to the services and size. And you pointed out to the differences between aged care and NDIS and a measure of some form of indirect regulation in the NDIS context through the direct imposition of an obligation to comply with a code of conduct. But in the aged care context, can I ask you, would it be appropriate that online providers such as Mabel, who are offering a platform on which personal care workers can be engaged and remunerated by Commonwealth subsidies, some form of regulation of those platforms is appropriate to ensure these minimum safeguarding steps that you've mentioned are taken?
So part of our qualified support there is not understanding what regulation is intended. So that's why there's qualified support for that. At some level in aged care, we think we operate within a regulatory framework because there is an approved provider allowing their clients to use the platform, and we're giving undertakings to them around some of the safeguards we have on the platform. And as you pointed out, in the NDIS environment, even unregistered providers are subject to regulation. They are subject to abiding by a code of conduct. They can be subject to complaints and incident reporting that can trigger investigations and workers being banned from the sector. Those sort of worker level regulations, I think, make sense. They have application across NDS and they have application across aged care. I'd like to see workers abide by an aged care code of conduct, but I'd also like to see some sort of unification of the framework that exists in disability with aged care, because increasingly workers are working across both client groups. And I think there's a real opportunity to create some uniformity and efficiency in how you might regulate workers.
What about the platforms themselves?
Yeah, well, and just workers that are, being able to regulate at a worker level, having some uniformity of approach would be better.
No, I understand you were saying that in your submission, but my question to you is, what about regulation of the platforms themselves, given that Commonwealth subsidy is being made available to remunerate the workers who are offering their services over these platforms, isn't it reasonable and proportionate that there be regulation of those platforms to ensure that at least the sorts of safeguards that you've spoken about, that Mabel is taking, the steps that Mabel is taking by way of safeguards, should be made mandatory for such online platforms?
I think a proportionate approach that understands the role of platforms, that they're not a provider, they're a platform that, platforms that introduce people, and that they potentially could be regulated to ensure that workers offering services via those platforms meet some of the regulatory requirements of those workers. And that's essentially the approach we would take in the NDES space. In any case, without it being formalised, it's the approach we take in aged care without it being formalised.
Operator, please bring up tab 82, Mr. Versteeg's statement. I've got to put to you a proposal that Mr. Versteeg is advancing to the Royal Commission, Mr. Scott. I believe this has been drawn to your attention.
That's correct.
Yep. So just very briefly then, Mr. Versteeg, in a passage beginning on page 0005, please, operator, at page 27, refers to one of the results of the adoption of consumer-directed care for home care packages and the phenomenon of the high administrative charges that you referred to, Mr. Scott. Mr. Versteeg points to one consequence of these things being a free market workaround, they're his words, that has been developed involving a broker operating outside the aged care regulatory framework. And I don't know whether you would accept the description broker. Is that a term that you would apply to?
Well, I think
yourself, Mabel?
No, no, we're not. We're a platform that introduces people, but I think this is a misconception about how Mabel operates within the home care package market because...
Okay, but just hold that thought. Okay. It may be relevant to a question I might ask you. So you don't agree with the description of broker. Mr. Versteeg says at 28 that the process is as follows. A broker, accepting that you disagree with that description, registers care staff who pass a police check, are adequately qualified professionally and have a current professional registration if required. Do you actually take those steps? Do you vet the qualifications of the people who load profiles onto Mabel?
That's right. So we have a thorough vetting process as part of the onboarding of workers on the platform. So they're all required to have police checks. They want to work with
I know about the police checks, but the qualifications. So if a worker says, look, I'm able to do enteral feeding, do you check that they've been trained in that?
So what our approach is, and that'll help answer the question, is that different services on the platform require different qualifications that have to be evidenced. So if you're offering social support and domestic assistance, there's no specific qualification. If you're offering personal care, we need evidence of a Cert 3 or a Cert 4 in individual support or aged care or disability support or a similar qualification. Within personal care, if you want to offer certain high-risk services like assist with medication, we look for that specific module in your training, which would be in a Cert 4 but not in a Cert 3. If you want to offer nursing services or allied health, we require your APRA registration and we will check the APRA database. So there's some really careful screening around qualifications, and within each category that people are approved, they can offer a restricted set of services. So a personal care worker can offer a number of different services that are available to be offered by the platform if they've evidenced their qualifications. So showering and dressing, toileting, assistance with medication. For example, they can tick various services. If they do tick assist with medication, it triggers a further check that they can evidence that they've done those services. So I can provide you with more fulsome information about the services, but if it gets into the sorts of services you're referring to, it's not going to be able to be provided by a personal care worker, it's going to be provided by a nurse. More than likely, it's a qualification that would fit within the nursing services that could be provided by the platform.
All right, well, perhaps that's right, perhaps that's not. Perhaps it could be done under the supervision of a nurse, but we'll move on from that. Thank you for providing that information. Mr. Versteeg goes on, care staff who pass vetting by the broker are listed on the broker's online platform. A package recipient selects a carer listed on the platform and informs their approved provider of their choice. He then says the package provider acts as a mailbox, receiving invoices and paying the invoices. And the broker pays the staff who have their own ABNs and are independent contractors, keeps their insurance up to date, etc. Now, he then specifically refers to Mabel as an example of this model in his opinion, and he refers to Mabel's charges being 5% charged to the home care recipient and 10% to the care worker. Is that how it works, or does that net out as 5% each, or is it 10% from the worker and 5% from the carers?
So the workers and their clients agree rates directly for each engagement. So if they agree $40 an hour, we add a 5% consumer platform charge, so that's $2 an hour, and we have a worker platform charge of 10%, which is $4 an hour. So in that case,
so you're getting 15% of the agreed amount.
Well, that's right. Or we're getting 14.3% of the amount the consumer pays, which is $42 in that example. So we're getting $6 on 42, which is 14.3% is the actual fee that Mabel ends up receiving in total.
And you've constructed that model, have you, as a competitor of the administration charges that home care package recipients are usually charged, and it's competitive with that administration charge?
No, I think they're unrelated charges. So the administration charge is for administering the home care package and making all of the things that go into administration charge. Mabel's fees are related to the connection by the platform and related really to more service delivery. So it would compare more to the traditional provider might charge $55 to $60 an hour to provide personal care and social support. If $40 is agreed between the platform, the total cost for delivering services is $42, and our fee is related to the delivery of those services. And it obviously covers far more than what's being suggested here. It covers, not only all of the screening activities, the actual building and maintaining of the platform, the insurances that the workers have the benefit of, but it covers things like access to our learning hub, where there's over 100 courses available freely. It's our whole incidents and complaints management process, which is incredibly comprehensive. So there's a lot more involved.
Thank you. Now I'll stop you there. I think you've probably gone beyond just answering my question, and thank you. Just to conclude, after making some points about whether there's in effect inconsistency or doubling up between the fact that a client is still paying an administration charge if they are to their provider, as well as the fees charged by Mabel, I'll pass over those and thank you for your information on that. Mr. Versteeg's conclusion is that the involvement of brokers without approved provider status in administering the home care package program should be banned in the interests of both consumers and care staff. And the point, I think, is he's not only making a point about the administration charges and the platform fees and whether there's, in effect, double up and unfairness to the consumer. I think he's also making a point that there's, as he puts it, a model here that takes the provision of care under home care packages outside the aged care regulatory framework over which the Quality and Safety Commission has scrutiny. What's your response to that point, particularly that safety point?
So I don't believe that we're operating outside the aged care regulatory framework. The aged care regulatory framework still imposes the responsibility for care management and meeting of the quality standards on the approved home care provider, who is allowing their client to engage a team of people via the Mabel platform, and still has ongoing supervision and oversight and comfort around the people they're engaging. So in the spirit of consumer-directed care, it's actually a way of empowering consumers to have more choice and control, authentic choice and control. And in terms of the cost of those services, using Mabel, you're doubling the hours of care and support. You're able to reduce your typical administration charge, of which we're not in our mind, not charging an admin charge, where our fees are in relation to the engagement of support and services. So it's essentially inherently part of the cost of engaging the service, not in the administration of the package or the funding. That rests with the approved provider. But the actual benefits of our model are quite profound, I think, to consumers and workers.
Aren't there going to be people who have complex needs, the needs for integrated care of various kinds, which will involve the need for a team-based approach, perhaps an interdisciplinary team, careful coordination about the medications they're receiving, the allied health that they need, the mobility strategies that they might need. There might be a host of comorbidities that they're dealing with. Doesn't need of that kind require, firstly, a team-based approach, and secondly, a direct employment model where there's close supervision of the way care is being delivered? I'm talking about home care package holders who might have needs of that kind.
No. I certainly accept it's a team-based approach. And I think one of the great things about Mabel is it can accommodate a medical model and a psychosocial model. You can build a team around your specific needs of nurses and allied health people if you need them, along with a variety of other services. So one of the things that we really emphasize is to build a team tailored to your requirements. I think there are some consumers that are particularly vulnerable, whether, as you point out, due to physical limitations or challenges communicating or just their social context. And it may be that an approved provider employs the staff may be a more suitable solution. But I also think, consumers have a great capacity to make decisions about what's important to them in their life, particularly if there's a care manager standing beside them. The care management function becomes incredibly important to be able to make sure you assemble a team that's consistent with your needs, your assessed needs. So I think, whilst I think there's some merit in that, I would look at the platform and say there are people with complex disabilities on Mabel that have a desire to manage their own team, and with the support of family and support coordinators and advocates, they're able to do that effectively. Now, that may not be the right approach for every person that's particularly vulnerable. So there needs to be different models available. And in some cases, Mabel won't be the right model for certain people.
I have no further questions, Commissioners.
Thank you, Mr. Gray. Commissioner Briggs, do you have any questions you'd like to ask?
Just one. It's really about the mechanism for ongoing training, learning and development. And if you were watching the session we had just before lunch, we were talking about the need for a significant transformation of the workforce to a genuinely person-centred model, but also the need to upskill the workforce. So I'd like to hear how Mabel goes around workforce learning and development, and how you would see a future model operating to accommodate your needs for upskilling the workforce.
So we are, thank you, Commissioner, we are absolute advocates of upskilling the workforce. We do that on Mabel through two main mechanisms. One, the workers that are approved on Mabel have access to our Learning Hub. There's over 100 courses there with subject matter experts ranging from core essentials, which could be safe at work or preventing and responding to violence, abuse and neglect, to the COVID-19 infection control training. So there's a bunch of courses available that we would think are quite core and essential. And then there's opportunities for upskilling and development across subjects to do with dementia or autism or person-centred approaches. We are absolute advocates of person-centred approaches up here at Mabel, and we have people that have spent 20 and 30 years advocating for that approach. The second main avenue we have is we proactively work with the TAFEs and RTOs around training opportunities for the workforce on Mabel, looking at where there are gaps. So, for example, we've recently worked with TAFE New South Wales around making 500 spots available for the new infection control skill set that's being developed. We're also having those conversations with TAFE in Victoria. We've also recently been able to offer workers on the platform an ability to start their Cert 3 by undertaking the first 4 modules free of charge, and then are able to complete it at a discounted rate. We've also offered through TAFE New South Wales 60 assist with medication opportunities that are fully subsidised. So we work very proactively with the TAFEs and RTOs. And one of the things that I think we've said in our submission is that, whether people are choosing to work for themselves or they're employed, they need equal opportunities to access training and development opportunities. So again, one of the core focuses could be to work much more closely in our mind with the vet sector to actually look at where the workforce gaps are and make sure that the right training is being developed. And certainly for us, person-centred is a really foundation skills, supported decision-making. We've run courses in that for workers on the platform in partnership with the New South Wales Trustee and Guardian. And those are the sorts of foundation skills we think all workers in the sector need.
Thank you.
Sorry, I didn't hear that.
Commissioner Briggs, I think we have a problem with the connection. We can't hear you very well. Mr. Scott, it looks to me as though a connection between you and Sydney seems clear enough. Can you hear me?
I can hear you very clearly, yes, Commissioner.
Yes, so it's the connection in Canberra that has gone down. We might just adjourn for just a minute or two whilst we try to remake that connection, Mr. Scott. Just don't disappear.
The Royal Commission is temporarily adjourned. Royal Commission is now in session.
Yes, Mr. Scott, I'm sorry for that lengthy interruption to our service, to our broadcast. And really, I just wanted to ask you a question about the matter that Mr. Gray raised with you earlier on. You'll recall that he asked you about our proposition H, or if I say his proposition HC6B, about suitable employment and engagement arrangements, and that the response from Mabel was described as qualified support. And then there are some words on page 13 in which the qualified support are set out. The general model that Mabel has can be described in all sorts of ways, and I don't really want to engage in broad and largely incomplete and not wholly accurate descriptions. But it's essentially a model, as you've described, as allowing people to connect with each other. And I understand that. No one would think of regulating the white pages just because you've got a list of plumbers that somebody can ring up from time to time. But this isn't quite that, is it? And the Mabel model does have terms and conditions with the various customers and clients. And one of the things that we could do is to recommend the regulation of platforms like yours so as to ensure that part of the terms and conditions of agreements that are entered into between the various participants pick up obligations so that, for example, the provider and the worker might effectively have the kinds of powers of direction and control that Mr. Gray was talking about. What I'd be interested to know from you is the extent to which your model is agnostic to that kind of regulation of you, and the extent to which regulation of that kind makes your model unworkable.
Okay. So I think, what is workable for us is that workers offering services via the platform, that the provider has some obligations around the screening processes that make sure those workers are suitable, from, police checks to reference checks to certain qualification checks, the sorts of things that you would think any platform operating this sector should do that's sensible. I think the only thing I'd probably like to consider is whether that changes the way our platform operates, to the extent that we are agnostic as to consumers engaging workers via a contracting relationship or an employment relationship. I think if I would just need to think through whether it has any implications if we're agnostic as to whether the provider was to have a different sort of relationship with the workers on the platform. Something right. I'd like to give consideration to, Commissioner, if that's possible.
Yes, no, I understand. It's a fair question, a fair answer to a question that you didn't have notice of. Yes, I think it would be useful to get an answer to questions like that. So some of the criticisms that are made of the Mabel model are, from your point of view, some of the features that make the Mabel model work more smoothly. And what I suppose I'm wondering about is whether one can have the cake and eat at the same time, namely whether you can allow your platform to have the kind of connecting effect between workers and those acquiring the service, whilst at the same time having the providers being able to direct and control some of the provision in a way that doesn't cause that blends both the overlying quality controls without necessarily making the model economically and or administratively unworkable.
I appreciate the proposition, and even as the model operates today, there is overwhelmingly positive outcomes as reported by consumers and workers in engaging via a model that connects people directly. So I think avoiding, losing the power of that ability to form relationships locally around mutual choice, I think is really important for the future of the aged care sector.
I understand that. And what Mr. Gray may say is that that's because we're very fortunate of having somebody like Mr. Scutt running it. But if it's not Mr. Scutt, but somebody else, how can one make sure that the good things that Mr. Scutt would like to have are the things that anybody else would bring to the table as well?
And I think in relation to that, having some, as we just discussed, some regulation around the sorts of things the platform might do to vet workers offering services via the platform are important, including things for us. We run a very comprehensive incidents and complaints management process. People can report them in multiple ways. We investigate them, we track them, we report on them, we assess them for continuous improvement. It's the sorts of things that you'd expect a well-run platform to incorporate into their operations.
Yes, thank you. Mr. Gray, is there anything arising on that? No, thank you. Thank you, Mr. Scutt. Thank you for your very considered and detailed submissions, both in writing and for being available for our questions today. We are very grateful and we are better informed, so thank you.
I thank you very much for the opportunity.
And I formally excuse you from further attendance.
Thank you.
Commissioners, time is getting on. However, we do have another witness we'd like to call. He's an overseas witness, so we would like to accommodate him now. I call Professor Dr. Jos Scholes of the Netherlands.
Here's Mr. Scholes.
Professor Scholes, can you hear us?
Yes, I can hear you.
Apologies for keeping you waiting, and thank you for your attendance. Well, the next voice you hear will be the associate. No, I withdraw that. The next voice you hear will be me again. Commissioners, I have an application to make that Professor Scholes not be required to give an oath or an affirmation before giving his evidence. That's because I have concerns that may involve notification requirements under such things as the Hague Evidence Convention, given that Professor Scholes is over in the Netherlands. I mean, it's a question of some uncertainty and difficulty, and I prefer to avoid the risk of triggering notification requirements.
Yes, thank you, Mr. Gray. I think in the circumstances, we won't require Professor Scholes to swear an oath or an affirmation or make an affirmation. Professor Scholes, it may be a matter of some bewilderment to you, all this. The oath or the affirmation is usually administered on the basis of a formal invocation of some higher order that you will tell the truth. We will now be left to your own good judgment to do so. Thank you.
Professor, what is your full name?
My name is Jos Scholes.
Thank you. And are you a professor of old age medicine? Is that the correct description?
Yes, that's correct, at Maastricht University.
Thank you. And what is your expertise and experience in the long-term care of older people in the Netherlands?
I'm a community geriatrician and nursing home physician since 1987, have worked in long-term care since 1987, and since 2004 in research related to old age medicine and chronic care at Maastricht University, where I have the chair in old age medicine.
Thank you, Professor. I'm going to ask you a series of questions, and I do ask that you indicate to the commissioners, to the best of your knowledge and belief, what the true and correct answers are. And if you don't know, please do say so.
Yep.
In summary form, what types of publicly funded support and long-term care services are available for older people in the Netherlands? And Professor, if you wish to respond by referring to the three key legislative pillars of the Social Support Act, the National Healthcare Insurance Act and the Chronic Care Act, please give a broad summary of the services under each.
Dear Council, there are 3 laws related to home care and long-term institutional care. People who need social support can apply to the Social Support Act, for which they have to go to the municipality, and the municipality can offer them standard services or customized services. Standard services, for instance, are facilities for social contact or Meals on Wheels service, so hot meal service. Customized services are, for instance, domestic help to clean the house, means to adapt the house to your disabilities, and possibilities to get wheelchairs or customized day activity programs. People who need nursing care at home can apply to the Healthcare Insurance Act, and this will enable them to get personal care or nursing care at home. And the Healthcare Insurance Act also provides the care provided by a general practitioner, a physiotherapist in the community, and also hospital services. People who need 24-hour residential care, so care in a care home, can apply to the Chronic Care Act. And the Chronic Care Act pays their stay and their care they get in these care homes. It's important to know that all 3 acts, the services you get from all 3 acts, can be provided in kind, or you can, in all 3 acts, get a personal budget. I checked that extra this weekend with an insurer to know if this is right. So all 3 can also be provide you a personal budget.
Thank you. And that personal budget can be spent at the discretion of the person receiving the care, provided it is on services that meet the legislative descriptions. Is that a correct assumption?
Yes. Yeah, that's correct.
Some slides have been prepared from OECD data, which I'll now ask the operator to display. They are at tab 86 of the General Tender Bundle, please, operator. While they're coming up, I'll just ask you, Professor, what is the distinctive mixture of different types of long-term care in the Netherlands when compared to other developed countries? And if you could answer by reference to institutional or residential care on the one hand and care at the home on the other, what is the distinctive feature of care in the Netherlands and its history?
Yeah. If I'm honest, I can mainly compare the Netherlands with other European countries. And in Europe, we have 3 models of care. The Netherlands has the Scandinavian care model, which means that there is an intensive professional care services at home and in institutions. You also have the continental model, for instance, executed in France, with almost the same amount of informal and formal care. And you have the Mediterranean model, for instance, in Spain and Italy, with mostly informal care and less developed formal care services. So the Netherlands can be characterized by the fact that there is an intensive professional care at home and also in institutions.
And how does the mix... I'm sorry.
That also means that we spend a lot of money to these long-term care services.
Thank you. And if we just look at the graph on the right-hand side, and operator, if you could expand that for people viewing the web stream, care in institutions. On that graph, we also have Australia in green, Netherlands in orange, and the OECD average in red. is this graph depicting that the Netherlands percentage of long-term care recipients by proportion to population is actually reasonably high, above the OECD average, but not as
Yes.
high as Australia.
Yeah, but it was even higher in before 2015. These are data from 2020. Before 2015, when the long-term care reform started, we were at a level of 7 to 7.5%. So before 2015, we were at the same level as Australia with, regarding care in institutions. But now we are downgrading the level of care in institutions to come to the European mean of around 3 to 4. So in the coming years, we will even go more to the OECD mean level.
So, Professor, just in summary form, why did the Netherlands decide to change direction and reduce the percentage of people who are cared for in institutions, and how has that been achieved? If you could answer those two questions together.
The reasons is that it was too expensive, and healthcare, we are very worried that we can't pay our healthcare services in the future. So that's why we started to downsize the care in institutions. It also fits in the preferences of older people themselves who want to age in place as long as possible. And how did we try to achieve it? We have tried to achieve it by making a long-term care reform and changing the laws. Before 2015, we only had a Healthcare Insurance Act, and we only had the Exceptional Medical Expenses Act. And after 2015, the Exceptional Medical Expenses Act was divided into the Social Support Act and the Chronic Care Act. And the Social Support Act was not paid anymore via the healthcare funds. And that means a reduction in healthcare funds.
So in terms of describing the practical effect of those legislative changes, what changes to funding were made or to other incentives were made that has reduced the number of people in institutions? And has that led to more support for them at home?
Yeah. When you want to diminish or decrease the number of people in institutes, of course, you have to take care of the fact that you empower the informal care at home and also the formal care at home. So extra efforts were made to empower informal care at home via support of the Social Support Act, and also to lead to more professional care at home. And how did we decrease the number of care in institutions? By making it more difficult to get an indication for residential care. So nowadays you only see people with very complex problems who get care in institutions.
Thank you. And in just taking one of the aspects of supporting people at home, which was providing them with, I can't remember the exact word you used, but higher levels of care. So separate from the support of informal care and focusing on the direct funded care that people receive at home, has there been more funding put into caring for people with complex needs at home?
Yes. When the Exceptional Medical Expenses Act was changed into the Social Support Act and the Chronic Care Act, also part of the amount of money which was in the budget for that of that original law was skipped to the Healthcare Insurance Act, by which it was able to provide more care at home.
Now, under the Chronic Care Act, if a person is indicated after their needs assessment for care in an institution, residential long-term care, but they choose to remain at home, is it true that they can take the funding that would have been provided for their care component in a residential care facility and spend it as a package at home?
Yes, that's I can only say yes because that's the truth. Yes, but you have people with very complex needs who want to stay at home while they maybe should be better off in an institute, and they can stay at home until the maximum of the care package which would be paid for in the institute. So if it's even more expensive to stay at home and even more care is needed and more money is needed, then they actually have to go to an institute. So it's right what you're saying.
And how is that working? Is that part of the suite of reforms that have had the effect of reducing the percentage of people who are in institutional care?
Yeah, that's working because there is an intensive contact between the providers and the client and his or her family at home. And there has a lot of efforts been made to further improve the concept of shared decision making. So there is a constant, and that is possible because the care is regulated via care plans. So if you provide care via a care plan and you see that the care is getting complexer and complexer, during the regular evaluations, you discuss with the client and his family whether it's still possible to get the care at home or not. And normally, in a rational way, this always gets to the right solution. Sometimes there are some problems if you talk about people who are cognitively disabled because they do not always understand the evaluations, and then you have to take some other measures together with their families.
Thank you. And does that involve, say, the appointment of a guardian to make decisions for the person?
Yep.
Now, could we just ask a few questions of you concerning the detail of assessment and funding under the three different legislative sources of funding?
That's possible, yes.
Thank you. So firstly, supports under the Social Supports Act.
Yeah.
You said that this is supports administered by municipalities.
Mm-hmm.
Does the funding of those supports provided by municipalities come from social insurance, taxation, or something else?
Now, the implementation of the Social Support Act is financed from tax money and personal contributions. The government manages this money and distributes this money to the municipalities through a special municipal fund. So it's a special fund developed for the municipalities, and it's not a fund belonging to the healthcare funds. The distribution of money mainly looks at the composition of the population in a specific municipality and to other characteristics such as the number of inhabitants, the number of old people, the number of the average income of people, etc., etc. So the government gives every municipality, according to some characteristics, money from this municipality fund, and from that the municipalities pay the activities from the Social Support Act.
Now, this next question, I don't know whether I should ask it specifically only about the Social Supports Act, or whether it might also be relevant to the other two acts, but I'll ask it anyway. How is the assessment of a person's need for social support made? And if it's made in a process which also involves assessment of whether care under the National Healthcare Insurance Act and possibly care under the Chronic Care Act is also required at the same time, please do tell us.
Now, there are, thank you for this question, Councillor. There are some differences, so I will try to be as short as possible. A request for care under the Social Support Act can be made at the social support booth of the municipality. Thereafter, a representative of the municipality, who is also part of the district social care team, visits a client at home and assesses together with the client which care is necessary in addition to the informal care which is already present. And after agreement, that assessment is the basis for the care indication to get the actual support. Do I need to tell it also for the other three acts, or do you want to wait with that?
I'll ask about those in just a minute when I come to them.
Sorry.
So thank you. So it is a separate assessment, and it also involves generating a plan with that municipal official.
Yeah.
Yep, thank you. Now, is there any need for monitoring the safety of the services that are provided or their quality, or is that something that is only done for personal care services and nursing services and similar things? So we're just talking about social support still.
Yeah, the care offered via the Social Support Act is done by providers that have been contracted by the municipality, and they have to stick to service delivery and quality agreements which are made nationally. So they must work according to national regulations on care and care quality, and must have an intrinsic quality system that is checked by external auditors or municipality judgments every year.
Thank you. Now, at the start of your evidence, or at the start of this session, you mentioned that all three kinds of care can be taken as a package, as a budget, I think you said, at the option of the care recipient or the support recipient. So with respect to social support, which is provided by direct contract between the municipality and a particular provider who has an agreement with the municipality, how does that budget work? Does the client get to choose between different providers?
The client can choose when the client has a personal budget, he or she can choose a provider, him or herself. But if the municipality, for instance, has a contract, a major contract with one of the larger providers in a municipality, then the client gets the service from that provider, and the municipality will say to the client, it's this or that provider who will come to your home to provide the services. And then they get the service in kind.
Thank you.
It's always the municipality who determines that in case of no personal budget.
Thank you. And where there is a budget, then the person has a choice to purchase those services from someone else. Is that right?
Yes, but then he also has to choose out of a range of providers who are accepted by the municipality. So it must be providers who fit into the national regulations, and it can not be an arbitrary provider. Yeah.
Thank you very much. I'll now ask about care in the home, which you've previously described to me as home care. This is the Dutch equivalent of home care. We have quite a technical expression for home care, but in the Netherlands, is home care the proper description of care that's provided under the National Healthcare Insurance Act to older people in their homes?
Yeah, and then it's in 99% of the cases, it's district nursing care. Yes, it's personal nursing care people get via this law.
And is it correct to say that there are a number of gradations of nurses, beginning with assistants who are in effect just providing personal care without any clinical element, going right up to highly clinically specialised nurses?
Yes, I can shortly summarize it by when a client at home receives nursing care at home via this law, the indication for this service is made by the district nurse, and the district nurse is a highly educated nurse who is the leader of a team of nurses from different educational levels, starting with assistants and going up to higher educated nurses, executing more difficult tasks, for instance, related to wound care or medication services, etc., etc.
Now, Professor, is this the Buurtzorg model? Is it this nurse-led model? How is that different from the Buurtzorg model? Is the Buurtzorg model a special version of this kind of care?
Yes, I shall try to tell it shortly. If you want to know more, if you want to know more about buurtzorg, you have to contact Jos de Blok, the CEO of buurtzorg, because he developed this model and he knows everything about that. Why did he develop this? He developed this because traditional home care services, the teams led by district nurses are part of large organizations with a lot of bureaucracy, and they do not have a lot of self-steering power. And Jos de Blok was the person who said, I want these teams really work together with clients and their families, and I want them give more responsibility, more self-steering abilities, and they must not suffer from all these large organizations, all these managerial layers in these organizations which keep them from their own work. So the issue is that in the traditional home care services, you have these teams led by a district nurse, and in the model of Jos de Blok, buurtzorg model, but in the model of Jos de Blok, they have more self-steering abilities and possibilities than in the traditional services.
Thank you. And just to be clear, the title district nurse, it doesn't necessarily mean that they're in charge of a district, I understand. It's a top tier of nurse.
Yeah. We call this we call this nursing services provided via the Healthcare Insurance Act. We call this district nursing because they always work in a certain part of a city, a municipality. But it's not I think that the meaning you give to the word district. I think this is much larger. But we call this district nursing, and we have stolen this name from the UK. It's not the right word to use in a hearing, but we use this because in the literature, the English literature, it's always referred to as district nursing. Yeah.
Thank you. Now, the funding arrangements for care under the National Healthcare Insurance Act, is that funding financed by social insurance?
No. The National Healthcare Insurance Act is executed by healthcare insurers, and they have budget agreements with individual providers, healthcare organizations. It's financed by healthcare funds from the government, not by social care funds. And nationally, the healthcare insurers receive their money from the government based on the actual number of clients and some other parameters they provide. And every citizen in our country pays an income-related premium related to the Healthcare Insurance Act. And if they actually receive care, there's also an own contribution for both care related to the Healthcare Insurance Act and the other acts. Yeah.
Thank you. So when I use the expression social insurance, if I take away the word social and I replace that with compulsory, government managed insurance, is it?
Yeah.
Is it financed by compulsory government managed insurance?
Yeah, that's right.
Yeah. Thank you. And let's ask now about assessment of need for home care under the National Healthcare Insurance Act. Is that done by the district nurse or by people under the supervision of the district nurse?
Yeah. It's done by the district nurse who determines the care indication and the extent of care which is needed. And there is a strong contact between the district nurse and the general practitioner. It's often the general practitioner who advises the family to seek for home care services via this act, because he or she sees that there are problems in the home situation and that nursing care is needed.
So the district nurse is both managing the team that provides the home care and doing the assessment.
Yes.
Who are these nurses employed by?
The district nurses are employed by the providers themselves.
And who appoints the providers?
Now, the providers are organizations by themselves. So, for instance, the organization of Jos de Blok or a traditional home care organization employs district nurses, and they have this task to do.
And can a particular person seeking care, home care under the National Health Care Insurance Act, choose their provider?
They can choose their provider, yes, indeed. But of course, again, it is important that the providers are providers which have been contracted by the healthcare insurer. So because the healthcare insurer is executing the Healthcare Insurance Act and they contract the providers, but if in a community or in a municipality or city there are 4 providers contracted by the healthcare insurer, the client may choose his or her own provider he or she wants to get care from.
Thank you. And I should know this, but how many healthcare insurers are there? Are there many, or are there just one?
Oh, no. I think, I don't know the exact number, but I can look that out later. But I think there are at least 10 to 15 in the Netherlands. Yeah.
And so this is a model whereby there's a compulsory premium under related to income, and it's it's made compulsory by government, and the insurance is managed by private insurance providers. Is that right?
Yes.
Thank you. Yep. Now, what about the regulation? Oh, sorry, I should just ask. Yes, the monitoring and regulation of the quality of the home care that's provided. How is that done, and who does it?
There is, dear Council, there is a national quality framework on district nursing, which applies for all providers of district nursing. The Healthcare Inspectorate in the Netherlands is monitoring the care provided by the home care services, and in addition to that, the care insurers who contract the care providers who provide home care, they may ask additional parameters, but mostly they try to tune that with the Healthcare Inspectorate. But the Healthcare Inspectorate actually monitors what's happening on the level of the client.
And how is the funding level determined by the insurer? Is that linked to the assessment of need by the district nurse?
The insurer always looks to historical data from the provider, and the amount of budget a provider gets depends on the number of clients the provider has, and the mix of care complexity which is provided by the care providers. So small care providers get lesser money than a larger care provider, but that is logical.
And turning now to the Chronic Care Act, is that insurance-based or is that funded through taxation?
The Healthcare Insurance Act is paid via a special law. The Chronic Care Act. Oh, sorry, I'm making a mistake. The funding by the Chronic Care Act is a separate funding provided by the government, and every citizen also pays a monthly premium based on their wages to pay for the Chronic Care Act. So they have a monthly premium for the Healthcare Insurance Act, but also a monthly premium for the Chronic Care Act. And the Chronic Care Act is executed by specific offices of the regional care insurers. We call them the administration offices, and they get their money via the government, also based on regional characteristics, number of clients they have to take care for, and developments in the past. And the care insurers, these administration offices, only contract acknowledged providers, and the clients, what I say, next to their premium they pay during their labor period, period in their times until they get retired, they pay also an income-dependent own contribution when they get the services. So I hope this is clear, or do I have to tell it again because it was a little bit disturbing in the beginning?
No, it was very clear. It was very clear. Thank you, Professor. You were talking about the funding arrangements under the Chronic Care Act and how the funds are financed, and it's essentially similar to the National Healthcare Insurance Act in that there are insurance arrangements through compulsory premiums paid by people during their working lives.
Yes.
Now, my next question is, how are those premiums determined? Are they uniform across the country? Do they depend on the chosen insurance provider? And are they calculated by some actuarial method?
Yeah. Care under the Chronic Care Act is provided by care packages. There are 10 care packages. So, and I will try to explain this shortly. If a care home provides care to clients, these clients get a care package. And for instance, care package 5 is the package for people who need dementia services. And care package 6 is for people who need physical care in the care home. And for instance, care package 10 is needed for people who mainly come to the care home for palliative care. Now, every care package is an organization gets an amount of money for every care package, but this differs because the lower care packages are not so expensive than the more complex, the higher care packages. So care package 10 is an organization gets more money for care package 10 than for care package 4, for instance. And how do organizations get their overall budget for this law? That is because the administration office of the insurer can look to the developments in the past in how the mix of care packages is present for this provider. And most care packages are related to 5 and 6, dementia care or somatic care, and the more complex care packages are always lower in number. And depending on the number of clients who get care package 5 and 6, there the main budget is determined.
Thank you. So that was very useful information about the funding levels or packages, to use your expression. Is that the Dutch word that's used? Is it package?
Yeah, we use it. We call it zorgzwaartepakket, care package. Yeah, we call it care package. Yeah.
And they are, in a sense, 10 different levels of funding, and the overall funding by the insurer of the organisation depends on the case mix or the mixture of levels across the population who reside in that organisation's facilities.
When this first started, you always have to look to the developments, but nowadays insurers can really see that that there is there's sort of a balance in the care in the mix, because when an organization has 500 beds for demented patients and 500 beds for people who need physical care, the care insurer office knows that they need 500 times care package 5 and 500 times care package 6, and that are the main care packages who are provided.
And the care package also describes a bundle or a group of services that are needed to meet certain levels of need, by the sounds of it, or certain kinds of need, for example, dementia care. Thank you. No, that was very clear. Could I go back and ask a question on an earlier topic of financing?
Yeah.
Under the two acts, National Healthcare Insurance Act and Chronic Care Act, that involve compulsory premiums. Compulsory premiums are levied on people during their working lives to help finance those two acts. Yeah. How are the premiums determined?
They are determined by the government.
Is it one premium across the whole country for every?
Yes. It's one premium for everyone, and
depending on income.
Yes, yeah, it's depend. No, it's one premium it's one. Now the premium is a percentage of someone's income.
Yep.
And the percentage is nationally determined. So if someone earns a lot of money, he actually has to pay more than someone who has to pay who earns less. But these percentages are determined by the government for both the Healthcare Insurance Act and the Chronic Care Act.
And do you know, Professor, these are questions without notice, forgive me. Does that premium, does the collection of those premiums fully fund the requirements under those two acts, or do they have to be topped up by taxation revenues?
I think it's a very important question because you see in general and in many countries that the costs for healthcare, they grow every year. So mostly they have to be topped up. Yeah.
Yep.
May I shortly repeat one thing? These premiums are paid during the work life, but when people actually get the care later, they also have to pay an own contribution. But that's when they get the care. Yeah. And that own contribution, in addition to the premium they have paid during their work life, is also depending on the income they have after their pension.
Yep, thank you. In the Netherlands, do you know what, roughly speaking, is the, I don't know, the percentage or proportion of people who choose to take their care as a budget rather than in kind?
I do not know it exactly, but I think I have to say only that the most care is still offered in kind.
Okay.
And that's I can honestly say between 85 and 90% is offered in kind. But I think in the future, personal budget will grow in number. And what you see, especially in the Netherlands, is that especially younger people who read them in very well into the services which are possible, especially the younger people who need chronic care, use more the services via a personal budget than the older people aged 70 and above.
Are you able to answer this? If it's too speculative, just tell me, but do you have an impression as to whether the provision of the care in kind is really best suited to being met by organisations that directly employ all their care workers and their nurses?
Yes.
And it is?
Yes.
It is better to be directly employed? And
yes.
Why is that? Is that because of the need for supervision, training? What is it?
When you see it positively, you can say it's because they have more influence on the quality control, the supervision, etc. But you also can see it a little bit negative, but I always go out from the best in people, is that if you see it negatively, it's because these providers have to keep up their organizations. So when they get the service in kind, they are more sure about the money they get every year.
Yes. Now, on the other side of, and on the other side of the coin, if it's an individual budget, even if that's only 10 or 15% of cases, or around 10% of cases, is it less important that the care be provided by organisations that directly employ their staff? Is there more room for independent contracting, or is that just not a feature of the Dutch landscape?
The issue is that there is more room for independent contracting, and that's why during the years in which we have experience with personal budget, there were some quality issues raised, because when the care is provided by a contractor who actually fits to the national regulations, then they are supervised by the Healthcare Inspectorate. But there were also contractors, independently contracted, which did not actually fulfill all regulations. And then you sometimes see quality issues raised later in time. And that has been an issue. And we are working on it to actually take care of the fact that even when someone has a personal budget, he or she should contract a a provider which has been contracted by the insurer.
Thank you. Now, I want to ask you, in the time we have left, a couple of detailed questions about the regime for monitoring quality and safety by the National Healthcare Inspectorate in particular. But if you want to tell us about the other methods of monitoring involving the use of accredited auditors, then please do that as well. What are the main tools that are available to the inspectorate and to the auditors? Are there quality indicators in widespread use in the different forms of support, home care, and chronic care when used in the home?
Yeah, and I think this is more general for all types of care, so that makes it a little bit easy. But every organization that is contracted to provide home care or institutional care is obliged to have an intrinsic quality system which is audited by an external organization every year. This intrinsic system makes clear how you have organized your services, how you check them, how you do your quality controls, etc., etc. Next to that, organizations having such an intrinsic quality system which is audited by these external organizations, they have to provide quality indicators to the National Healthcare Institute. And these quality indicators provided to the National Healthcare Institute, who assembles all these quality indicators from the different institutes or organizations, can be checked or looked in by the Healthcare Inspectorate. Now, for home care, there are three types of indicators at this moment. For home care, we have the Net Promoter Score of clients. The Net Promoter Score is a score in which clients and their representatives judge via a figure how they assess the quality of the provider. Figure 1 is very low, figure 10 is very high. There's also, these organizations also must provide an indicator which shows how active they are to improve this national Net Promoter Score. And they have to provide an indicator which assesses the extent to which client data are systematically and automatically registered in the right way. So if you provide care at home, do you gather the data you need to provide tailored care to the client? This is for home care organizations. If you look to institutional care organizations, you mean care homes, they also have to provide the Net Promoter Score. They also have to provide data on safety indicators for clients. For instance, the prevalence of pressure ulcers, the prevalence of malnutrition, the use of restraints, an indicator on medication safety, and on advanced care directives. And at this moment, we are developing for both sectors, the home care sector and the institutional care sector, we also develop qualitative instruments which use a narrative approach to assess the client experiences related to, respectively, home care and institutional care.
Thank you.
Every year, every year,
Please.
the Healthcare Inspectorate and the insurer visit the organization, the home care organization and the care home. They can use the data from the National Healthcare Institute to get an overview on how this organization is performing, better or worse than the mean, better or worse than other organizations in the region. And they can visit these organizations, talk with the director, talk with professional, talk with clients, talk with family to get an overall view on how the institution or organization is performing. And the Healthcare Inspectorate finally makes a report of every visit they make with the recommendation to improve care at different points they see which are not sufficient enough.
And you said every year. Is that the same for every provider, irrespective of how good or bad their performance has been in the past?
I have to be honest, it's meant to be done every year. The insurer every year visits, that's true. The healthcare inspectorate wants to do that every year, but if we look to daily practice, they mostly visit an organization once per 2 or 3 years because they have a personal, they do not have enough inspectors to do that in every organization in the country. But in fact, they aim to do it every year. At least they look every year to the data provided by the organization. And if they see something which is not going good in the data, then they actually will come. But mostly the healthcare inspectorate does it once per 2 or 3 years.
Thank you. Now, you said in home care there's those 3 indicators.
Yes.
2 of them around the net promoter score or activity to improve it.
Yes.
And there aren't any objective clinical care indicators that are applied in home care. That's home care provided under the National Healthcare Insurance Act. Correct, Professor?
That's correct at this moment. In the past, there were some indicators, but nowadays we only have safety or clinical data related to institutional care. But I know that in the near future, also in home care, some of these clinical indicators will be used again.
Oh, is that so?
Yeah, but shortly, in addition to my information, is that it was reduced because of the reforms in home care. And the government and the healthcare inspectorate wanted to reduce the bureaucracy for district nurses and other nurses in home care, because we have a lot of problems to get enough staff working. And that's why they wanted to reduce the bureaucracy. And that's why they didn't oblige anymore to have also these clinical indicators, but they will come back in the future.
If we go to the slides that the operator showed us before, and if we go now to slide 6, I beg your pardon, slide 5, which is page 0005, please, operator, we see that for home care, which is the figures along the top half of the page,
yes,
we see that there's home care recipients in each year age 65 or over, and there's a series of years starting in 2005 going through to 2018.
Yes.
And in 2015, there's quite a large drop in the numbers of people receiving home care who are age 65 or over.
Yes.
The figures go from about 380,000 to 260,000.
Yes.
Now, this was also happening, that downward trend was also happening in institutional care.
Yes.
Is that part of the reforms, the reform process you were talking about?
Yeah, I think this is a very nice slide because it clearly shows what happened since 2015 when the Chronic Care Act came into force and the Social Support Act. And the care provided by the Social Support Act is not shown in this slide because it is not provided via healthcare funds. And that's the reason. And you
Thank
really...
you. So,
okay, that I stop, yeah.
Yep. So in short, while it looks like over 120,000 people have disappeared, they haven't disappeared.
Yeah.
They've been moved on to support by the Social Support Act.
Yeah.
And indeed,
yeah.
Indeed, there's probably more than that being cared for because there's been a drop in the number of people in institutional care, and they're probably being cared for by home care at about this time, from about this time.
Since 2015, also the number of institutional care clients dropped, what I explained to you already, because there is a focus on aging in place. And the people who stay longer at home, they get services from either via the Social Support Act or the National Healthcare Insurance Act. Yeah.
Yep, thank you. Now, with respect to the quality indicators, in 2015, those safety and clinical indicators in home care were taken away, were disappeared, but now there's a proposal to bring them back. Is that because there's been a consensus of expert opinion that in fact they are a good idea to have them in home care after all?
Yeah, let me clear. In the Netherlands, most care offered at home and care in institutions is offered by organizations who have home care services and care homes. For instance, I am working in Maastricht for 1.5 days still in a large chronic care organization who has a very large part of its services provided by district nursing and also has 15 care homes. And what we try to do, the problem of the current services is that they are good of quality, but they are rather fragmented. So home care is organized via the Healthcare Insurance Act. Nursing home care is offered via the Chronic Care Act. And what we want to thrive for in the future is to get more integrated care. So what we know is that an organization which provides home care and nursing home care knows the client already when he gets home care. And when the client is admitted to the nursing home within the same organization, in fact, you should achieve more continuity of care, which also means that you should look to quality more in continuity and not fragmented. But the issue is why the clinical parameters stopped in home care is that we started in 1998 with only one clinical parameter in care homes and in home care, which was the prevalence of pressure ulcers, which is a very major problem in chronic patients. But thereafter, there was an intensive growth of parameters: malnutrition, restraints, continence, etc., etc., etc. And that's why we said when this quality framework started, we stopped with all these clinical parameters and try to choose together with the clients, together with the families, and together with the organizations and professionals in the future, the new clinical parameters we actually need. In nursing homes, we had 12 to 20 parameters, and now we have only 5 of these clinical parameters. I mentioned them already.
Yes.
But the quality framework of nursing homes was established earlier than the quality framework of district nursing. The quality framework of district nursing came into force 2 years ago, and now we are developing gradually also new clinical indicators, but with the aim to have a low number of that, not too many, because people are really complaining about the bureaucracy when they have to provide so many figures to the National Healthcare Institute.
I'll ask the operator to display tab 62. This document is a list of potential home care indicators that could be collected from existing Australian administrative data, Professor, and in a home care context. And if we go to page 0312, we see the beginning of the list. And if operator, if you could call out just the base of 0313 as well and display them together, we'll get the entire list. I repeat, these are just potential candidates for quality indicators in home care in Australia. These are not currently being collected in home care in Australia. Professor, do you know what is the progress of the thinking about the development of quality indicators for home care in the Netherlands again? Which clinical indicators are considered to be appropriate for reinstatement as quality indicators for home care in the Netherlands?
In the Netherlands, we are also very interested in the use of multiple drugs, so polypharmacy. We are very interested in the use of psychotropic drugs, which means high sedative drugs or antipsychotic drugs. We are very interested already before we had suffered the COVID pandemic in the use of antibiotics. So in the use of, in the way infections are treated. And we are very interested in falls. When I use these ones, yeah.
Yep. Thank you.
But that's but you can look to outcome parameters or you can look to process parameters. If we look to polypharmacy and look to, for instance, advanced care planning, there we are also experimenting nowadays more and more with indicators which look to the process of care. For instance, the use of medication reviews is also a parameter we are testing at the moment, because you can look to how many patients use 29 drugs or more, but then you still do not know the process, how this is managed. If a patient has many drugs, it's important to know whether the medication is regularly reviewed. That's why we are now also experimenting with process indicators. And the same counts, for instance, for advanced care directives. You can look to the number of patients who have an advanced care directive, but you can also look to the process. Are there regular meetings with the client and his or her family to talk about proactive care planning?
Couple of further questions, Professor. If a person has been assessed as indicated for help under the Chronic Care Act, so that they could go into a care institution, but they choose to remain at home, do the quality indicator regime, do the quality indicators get collected for them at home? Do you know?
Yes, because I have to be clear about that. When a person is indicated to get care in a care home, but he chooses that he wants to get the same care package at home, then it's mostly the organization who provides the care home services who also provides the care in the home situation. And then this care falls under the Chronic Care Act. And then the same indicators apply for people who are admitted to a care home.
Thank you. You mentioned that the quality indicator data goes to the National Healthcare Institute. Is that a repository of these data and other healthcare related data?
Yes, yes.
Is it made available? Is it made available to the public? Is the public able to see how a particular provider performs on these metrics?
Until 2018, so 2 years ago, the clinical data were mostly assessed by independent institutions. For instance, our university does already for many years research on safety indicators, and we made the national reports. Until 2018, also the healthcare insurers made national reports about the data they gathered. But since 2018, since these data go to the National Healthcare Institute, they are this is a repository, and the National Healthcare Institute makes national reports, and in the future, national dashboards in which you can compare organizations in the country very fastly, so mostly digitally. Yeah, but they have to start with that activity still, and they would have started with it in this year, but because of the COVID pandemic, this has been delayed.
And will this be the new form of performance rating of providers? I understand that the Netherlands has moved away from an index that used to be published.
Yes.
And is this going to be the new form of performance rating by which the public can judge between providers?
Yes. But there are more developments, because you can judge a provider only on clinical data, you can judge a provider only on qualitative data, and you can judge a provider on how he's performing financially. And we are now thinking about developing new types of looking to quality of care, new dashboards, which show how a provider is performing on clinical data, on safety data, how he's performing from the judgment of clients and families, how he or she is performing on the judgment of its personnel. For instance, what's the number of sick leave, what's the percentage of sick leave, how do healthcare staff experience the care they provide, and on financial data. So we are now gradually thinking of the development of a more comprehensive way of looking to quality of care. Because, for instance, a short example, if you have an institute which is very medically oriented. If you have a care home which is very medically oriented and they provide perfect pressure ulcer care, maybe this institute is not performing well if you look to daily life for clients, for daily activities, and for welfare. And clients, they always also look to that type of aspect. They also want to enjoy their meals, their activities, the way they can get socially participation when they are in the institute, etc., etc. So that's why we are now thinking about a more comprehensive approach to quality of care, and that all data from the National Healthcare Institute may be used to develop such a picture which looks to quantitative data, qualitative data, financial data, and staff experience data.
Thank you, Professor. I have no further questions.
Yes, thank you, Mr. Gray. Commissioner Briggs?
No questions, thank you. Thank you, Professor. That was very interesting.
Thank you.
Yes, indeed, Professor. It was exceptionally interesting. We really are indebted to you giving up your morning to us. It's been very, very informative indeed, and will develop our thinking significantly. So we thank you for your time and services, and I hope you enjoy what is left of your beginning of autumn, I presume.
It's still early in the morning and I will go to work now. Yeah.
Thank you.
Thank you, Professor.
Bye-bye.
Thank you.
I presume, Mr. Gray, that I don't need formally to excuse this witness.
We didn't.
Subpoena.
No. No, that's correct. Thank you, Commissioner.
Thank you. Anything else tonight?
No, that's the business for today.
So we'll adjourn until 10 o'clock tomorrow?
Yes, please.
Very much.
The Royal Commission is adjourned until 10 a.m. on Tuesday, the 1st of September.